And why I call disaster is because if not managed in time and if not managed properly, this can lead to irreversible loss of vision, and which I label as phthisis bulbi. Is it moving? Yeah, this can happen. So this brings, especially to a surgeon who operates. Believe me, I personally have had a couple of incidences where, we had to close the operation theater and, smile goes away from the operating surgeon. So two things we are always bothered is today because of Google and so much knowledge, we see a lot of court cases are going on. And as I said, patient, sometimes may lose vision also despite the best efforts. So how to save these eyes is, as is usual, either you prevent this from happening or you do a prompt treatment. As far as prevention is concerned, you see there are a lot of things, which are taken into account pre-operatively. All of us rule out sources of infection, and per-operatively, all this reality and good quality irrigating fluids. Betadine is one thing which is level 1 evidence, and we always drape to isolate the lashes. And very important thing is good wound construction, because I believe if wound is good, then the possibility decreases. And when in doubt, always put a suture. The intracameral moxifloxacillin also has taken the world by storm, and it has become standard of care in a lot of institutions. And once the patient develops endophthalmitis, I believe intravitreal antibiotics is the mainstay. And if you are lucky, organisms are sensitive, and if you inject early, believe me, results are pretty good. Only thing is, if you inject late, then it becomes an issue. And then vitrectomy may be resorted to. And these are a couple of tips, I had jotted down that you should always suspect, try to differentiate from TAS, and prompt interval injection should be given. Early vitrectomy should be advocated, and document whenever possible. Because if you document, then it can save you from court of law. And always remember, if you don't document, it is thing that it is not done. Not document means not done. So key issues always are delay. And one delay is to differentiate from TAS. Second delay is to, not giving intravitreal injections in time. So this is one patient who was repeatedly, having bouts of inflammation, but this turned out to be a P. acne infection, and I had to do a vitrectomy in this. This was in contrast, referred for a urgent vitrectomy, but it turned out to pure inflammation. And why should we differentiate TAS from endophthalmitis? Is because pathogenesis of both these things are different, and treatment is vastly different. And prognosis and outcomes also are variable. TAS was defined long back, more than a couple of decades back, acute non-infectious inflammation following the surgery. And exact incidence is, very difficult, but mild cases can be missed also. And I believe TAS virtually happens in a mild form in virtually all of us, all of the patients. And finding an etiological factor is a challenge, and often, believe me, causes can't be pinpointed. And whenever there is a shift of, ringer lactate or trypan blue or any other thing, this is the time when most of this may happen, because a lot of people shift for cheaper substitutes. So causes which have been implicated includes viscoelastics and even IOL and phaco handpieces, or things like preservatives, or even intracameral moxie also have been blamed, and solutions and irrigating fluids have been blamed often. What is important for us is to recognize most of the time symptoms will develop very fast within 12 to 24 hours. And typically you have a limbus to limbus corneal edema. And IOP is not low in contrast to infection and endophthalmitis. IOP is normal or raised in these situations. This endophthalmitis we define as exudates in the vitreous cavity, which is accompanied by inflammation of the inner course of eyeball. And signs and symptoms can be very, very similar. And this is one chart which, sometimes can help you to differentiate between TAS and infection. Lid edema and chemosis are generally signs of infectious endophthalmitis. And corneal edema is localized in infection, whereas profuse and limbus to limbus in patients of TAS. So, but in any case, if a patient has unusual pain, lid edema, chemosis, and decreased vision after initial gain, or a hypopion, or very definitive vitreous exudates, in such situations, it's always better to treat these patients as infection, and immediately intravitreal antibiotics should be given. So I'll just take you through a couple of cases from our library. This, were two patients who had more than usual AC reaction, more than what the surgical trauma had caused. So here we always resort to, differentiation, whether it is TAS or infection. And in this particular patient, we gave steroids by all the routes, loaded the patient with steroids. But important is to follow these patients very, very closely. So this was the patient at presentation. And you notice, there was some glow there. The fundus picture not very clear. But we treated this patient with steroids and followed this very, very closely. And you see over the course of, day 14, this patient recovered only with steroids. This was that lady whom I was referring to earlier. This patient had some eventful surgery, and this patient again was loaded with steroids. And you see how this there is a resolution by 2 weeks. Patient gained again. No intravitreal antibiotics were given in this. But this patient who had all the telltale signs of endophthalmitis, immediate intravitreal antibiotic has to be given. And whenever we give antibiotics, we always cover for both gram positive as well as gram negative. And typically we give vancomycin and ceftazidime. Nowadays, the sensitivity of ceftazidime to gram negative is on the decline. So a lot of people prefer imipenem if they are suspecting pseudomonas or any other gram negative. And this is the chart we generally stick onto the operation theater wall so as to prevent dilution errors. And here the dosage of all the antibiotics, how to prepare, how to dilute them, including the imipenem and piperacillin, is all listed here. How to give is we always decompress the globe because we have to inject 2 antibiotics. It's always better to decompress, and various ways of decompression includes biopsy or aqueous paracentesis. And we also give this patient topical supportive treatment as well as oral steroids because all these patients have infection plus inflammation. And relevant is that follow these patients, first 1 or 2 days are very critical. Any worsening means start preparing these patients for MIVS or refer these patients for vitrectomy. This is one patient whom I shown earlier. This patient received intravitreal vanco and ceftazidime, but fortunately for me and fortunately for the patient, this patient responded and it was sensitive to these antibiotics, and it took nearly 3 weeks for us to have a clear picture and patient improving also. But believe me, all patients are not lucky to have improvement like this. There may be partial response or there sometimes will be no response also, primarily because either the organisms are not sensitive or the load of infection is very high. As you see in here, load of infection is very, very high. In such situations, we prefer vitrectomy to be done because I don't believe that you keep giving repeated intravitreal injections in these patients. And whenever we do vitrectomy, it has to be a near complete or radical kind of vitrectomy. And we don't hesitate to go close to the retina. We don't hesitate to peel off the hyaloid. And we frequently use silicone oil in these patients of severe endophthalmitis. And before you go into the vitreous cavity, it is always prudent to clear off the anterior chamber. Here, what we are showing is the use of an AC maintainer because we're not sure of the intravitreal entry. And then we protect the endothelium by another tab incision. And before we enter the vitreous cavity, it is very important to clear off this membranous structure in front of the IOL. And because if you don't do that, and in fact you enter directly, then you may do a messy job. And once this is done, then you go inside the vitreous cavity, clear off all the exudates, and then come out. This was another patient. The anterior chamber was flat. We used a 6 mm cannula so as to have an entry into the vitreous cavity. But here, instead of entering from the anterior chamber, because we entered from the pars plana, made a iridotomy, and from the pars plana area by tenting it, and then introduced various instruments to clear off this muck in the anterior chamber, which included cutter, use of MVR blade to tease away all these exudates which are obstructing the view of the vitreous. And after this was done, then you enter the vitreous cavity and you depress from all the quadrants. Then you get a reasonably good glow. And in this patient, then we did an endosiridotomy and injected silicone oil in this patient. This was another patient who had a radical vitrectomy done by the same procedure. And this was a patient who presented with corneal abscess with PL plus vision only. And at 4 weeks with silicone oil inside, he had 6/24 vision. And the steps of surgery are similar, that you use a direct entry, then you clear the anterior chamber first after having injected some visco to protect the endothelium. And in this patient, we actually ended up removing the intraocular lens. And this intraocular lens had only one haptic, meaning this was an eventful surgery done at the primary level. And you see the one haptic is missing here. Then this aphakic, now it's a pupillary area is aphakic. Then you become very bold to do this clearance of these exudates and remove every bit of the exudate from the anterior chamber. And before you start indenting and removing all the vitreous exudates. We have sutured the wound also. And finally, we get a good glow and inject silicone oil. Fungal endophthalmitis is difficult to treat, although voriconazole and amphotericin are available. But believe me, by and large, a lot of these patients of fungal fusarium or aspergillus require multiple vitrectomies and vitrectomies. And this was one patient who had a multiple vitrectomies, but the only thing which was not done was peeling of the hyaloid. You see, a lot of these exudates have collected underneath the hyaloid here. So what we did in this surgery was that we peeled off this hyaloid with the help of this backflash needle, and once this membrane or hyaloid was removed, then this patient had a remission. This was the end result of one of the patient of fungal endophthalmitis, which was traumatic. There could be another set of infections which are chronic and recurrent. Here, the usual antibiotic may not help because the bug is within the capsular bag. So here, the vancomycin has to be given in the bag, or sometimes IOL may have to be removed also. So this was one patient where we injected in the bag vancomycin and ceftriaxone, and over the course of 5 weeks, 6 weeks, in fact, this patient recovered some vision. This patient also had similar infection, but we had to go inside, do a vitrectomy, make an opening in the capsule, and ultimately patient recovered. This patient, however, was not lucky. We had to do, remove the IOL also because this patient was not responding to any other means. So we, did this SICS kind of section here and manipulated the IOL, brought out the IOL from this section. And once the IOL was out, all maneuvers are made to remove this, all the capsular bag, because you have to indent and remove this capsular bag with the help of suction only of the cutter. And this, because the bug is in the capsular bag, and this result was good. Last is that after intraocular injections, whether it's Avastin or Ozurdex or Lucentis, all this sometimes may have infection because an organism can be introduced while you are injecting. And because inoculum is high in such patients, these patients, have to undergo vitrectomy most of the times. And if the cornea becomes bad, then you have to take help from the cornea colleague. He will come and, do this removal of this button and then put a temporary keratoprosthesis. And this total infection has to be removed by the corneal surgeon. And then, this temporary keratoprosthesis is inserted. And after that, we then enter the vitreous cavity and do a thorough vitrectomy as is shown here. Then these patients may have some residual infection. I would just like to conclude by saying that, these patients have, a sad scene. You have to ensure privacy, empathize with the patients, trust patient cooperates with you, talk to them, and summarize your plan of action. And document always these patients. And again, those 10 tips which I had written in the beginning: suspect, differentiate from task, talk, prompt injection, and prompt vitrectomy should be done in patients who are suitable, and documents, and never hesitate to refer to a higher center if you're not comfortable. So key words are suspect, react, and act very promptly. Whether it is injections or vitrectomy, then only you can hope for some good gratifying results. And then smile can come back on the face of not only surgeon, but also the patient also. Thank you very much for this opportunity. Thanks a lot.
Thank you, Dr. Lalit. That was a very interesting situation and you've summarized it very well. Act, react, is what is the key in endophthalmitis. Do we have any questions for him?
Muted, Ajay, you are muted.
Okay, so then I would invite the second speaker. I think Dr. Claire needs to leave early, so can we invite her first?
I have to do the same thing, unfortunately.
Oh, okay. Okay, so then we have Dr. Peter talking to us about scleritis, and I think survival in scleritis for both the surgeon and the patient is important. So I asked Dr. Peter McCarthy to speak on scleritis survival guide in, well, under 15 minutes. Okay, that's an interesting challenge. Please, all yours, Doctor.
Great. Thanks very much, everyone. It's a pleasure to be here. As you all know, scleritis classification was developed by Mr. Peter Watson. It's been around for 50 years and it works incredibly well. Non-necrotizing and necrotizing, diffuse nodular and necrotizing. The characteristic symptoms of scleritis are pain, which is dull and boring, often the worst pain that the patient's ever had, wakes the patient from sleep early in the morning, typically poorly responsive to analgesics. And often these patients have been investigated for many different causes. There are a range of signs, the most important of which is a red, tender, painful globe. And there are these characteristic signs of scleral edema, vascular dilatation and closure. And you can often see nodules and frank areas of necrosis. The most important signs are these changes in the relationship between the episcleral vascular plexuses, which tell us that there's scleral edema, and we must look for vascular closure in the microcirculation. Natural daylight is very useful for examining these patients, as is the red-free beam on the slit lamp. And there's a range of severities of anterior scleritis, from diffuse, which is the commonest form, to necrotizing, which is the most severe and the greatest threat to vision, but is fortunately the least common cause. A keratitis is a very common association with scleritis, and it can range from very localized forms of scleritis to severe, widespread necrotizing forms of scleritis and melts, which are a severe threat to vision. These very commonly occur in rheumatoid arthritis and ANCA vasculitis. Posterior scleritis has been underappreciated in the past. We can use that same classification of diffuse and nodular. We can't diagnose necrotizing posterior scleritis except during an operation when we can see it, or pathologically. There's a range of physical signs that I'll briefly go through, and just like anterior scleritis, recurrences are common, and a significant number are associated with systemic disease. One of the commonest things that we see is posterior scleritis involving the posterior pole, where it can be a subretinal mass, a swollen disc with retinal folds and macular star, choroidal folds, or a serous retinal detachment. Less commonly, the peripheral sclera can be involved, so that you get a choroidal effusion, often serous retinal detachments as well. And from ciliary body rotation, you can get secondary angle closure, a shallow AC, and a very high intraocular pressure. It's also important to realise that we not uncommonly see posterior scleritis with anterior scleritis, as is illustrated here, and occasionally we just have pain and a tender globe and decreased vision with really no other signs. Scleromalacia perforans is an important but now extremely uncommon form of scleritis that's basically only seen in patients with advanced rheumatoid arthritis. It's asymptomatic and the patients present with blurred vision, and it's due to vasculitis involving the end arteries in the sclera. SINS, or surgically induced necrotizing scleritis, used to be common when we did large incision cataract surgery, like this extracapsular incision, but these days it's mostly infective, and particularly following operations such as pterygium surgery. And infective scleritis is something we always need to think about. It's, depending where you are in the world, anywhere from 10 to 30% of the patients with scleritis that you see, typically in necrotizing scleritis, can be a wide range of exogenous organisms. Occasionally we can see it with TB, and in India it's more common than in other parts of the world, sometimes with severe intraocular infection, and occasionally from contiguous spread, particularly by herpes viruses and acanthamoeba. There are a range of important systemic diseases associated with scleritis. Rheumatoid arthritis and ANCA-associated vasculitis are still the most common. It's important to remember B27-related seronegative arthritis, a range of other systemic vasculitides, things, rare diseases like relapsing polychondritis, and uncommon diseases like IgA nephropathy. The diagnosis of scleritis is all about the clinical assessment. Mr. Watson always used to say, if you didn't suspect the diagnosis by the time you'd finished taking the history, you probably wouldn't make the diagnosis. And it's really the history, the examination, and a careful review of systems that's focused on detecting symptoms of the common associations. There are a wide range of investigations that we can do, the important ones being a chest X-ray, ANCA serology, rheumatoid serology, and syphilis serology and TB serology. And there are a range of other imaging studies that we can do. There's really no specific good treatment guidelines for scleritis. There's certainly no randomized controlled clinical trials. And it's basically a stepped systemic approach to treatment where we use non-steroid anti-inflammatory drugs and oral corticosteroids for the mild and non-necrotizing forms. And for necrotizing disease, we need aggressive combination immunosuppressive therapy with high-dose oral steroids, second-line agents like cyclophosphamide and methotrexate, and where they're available, biologics are really proving to be very useful, particularly TNF blockers and B-cell depleting agents like rituximab. So the key messages for you to take home about scleritis is, although it's rare, it's an important disease. Mr. Watson's classification is the easiest and simplest way to get the types of scleritis in your head. Very commonly associated with systemic disease. The more severe the scleritis, the more likely there is to be a systemic disease. Necrotizing scleritis is a marker of life-threatening systemic vasculitis. Always think about infection and TB. And we have a sort of stepped algorithm of treatment from NSAIDs through steroids to combination immunosuppressive therapy and biologics. So thanks very much. That's a very quick tour through scleritis, but it's got the major messages there. It's been a pleasure to be part of this symposium. I hope everyone enjoys it.
Thank you, Dr. Peter. And may I now invite Dr. Claire Fraser she'll be talking to us about sleep apnea in neuroophthalmology.
Thank you very much for the invitation to be part of this conclave. I hope you can all see my slides okay. So obstructive sleep apnea is the repetitive, partial or complete collapse of the pharynx with resultant hypoxia at nighttime. In India, based on some data from ResMed, it's about a 13.7% prevalence, higher in men than women, and significantly higher in men over 60 living in metropolitan areas, and much lower in rural India, though whether this is because of poor diagnosis, I'm not too sure. The gold standard diagnosis is an overnight polysomnography, where they measure apneas, which are a reduction of airflow to less than 10%, and a hypopnea, which is a reduction of airflow to less than 50% with a 4% oxygen desaturation. So we can classify sleep apnea as mild, moderate, or severe, depending on this AHI. It's very important to diagnose obstructive sleep apnea because it does result in increased morbidity from diabetes, cardiovascular disease, hypertension, as well as an overall increase in mortality. And it reduces all quality of life measures and is independent. The risk of this is independent of the comorbid obesity. It's associated with a range of ophthalmic conditions, including keratoconus and floppy eyelid syndrome, worsening of diabetic retinopathy, central serous retinopathy, glaucoma, NAION, and as I'll show you, now also thought to be related to idiopathic intracranial hypertension. So what is the evidence for a link between obstructive sleep apnea and non-arteritic anterior ischemic optic neuropathy? Well, firstly, there is a plausible pathophysiological process. The sympathetic overactivity and surges in blood flow velocity caused by the sleep apnea impair the plial vessel autoregulation. The associated hypertension, atherosclerosis, and arterial stiffness alter the blood flow, and the direct hypoxia, as well as all of these, lead directly to optic nerve head ischemia. In past papers, they've shown that patients with NAION have a significantly higher rates of obstructive sleep apnea compared to control populations in the same group. And we also know from this large Korean-based study that the hazard ratio of NAION is significantly higher in patients with known obstructive sleep apnea. It's also been shown in particular to be related to patients who get NAION under the age of 50. So certainly if you have an NAION patient under 50, we'd be strongly recommending screening for obstructive sleep apnea. So the question then is, does treatment for sleep apnea mitigate this risk for NAION? And definitely the studies are showing that it does. We know that if you have untreated obstructive sleep apnea, there is a 16% increased hazard of developing NAION, and this is based on a US population database. And in this study, they found that obstructive sleep apnea was associated with an increased rate of NAION occurring in the fellow eye. And what was particularly interesting is if the patients were CPAP non-compliant, that was particularly related to fellow eye involvement in NAION. So I think we've got good evidence that obstructive sleep apnea is associated. So what about this link with idiopathic intracranial hypertension? Again, we know that the swings and elevations of intrathoracic pressure increase the venous pressure. The hypoxia and hypercapnia, of the sleep apnea, as well as the sympathetic overactivity, result in cerebral vasodilation, increasing intracranial pressure, and the direct hypoxia coupled with all of this result in worse papilledema. We know that from some background research that optic disc swelling is seen at high altitude related to peripheral oxygen saturation. And interestingly, we also know that patients on CPAP treating their sleep apnea show a 4% decrease in total brain volume. So there's certainly some plausible pathophysiological links here. Looking at patients with papilledema, we know that if you do overnight pressure monitoring, that they get nocturnal spikes in their intracranial pressure related with these episodes of apnea and arterial oxygen desaturation. So the episodic hypoxia and hypercarbia is resulting in this cerebral vasodilation and the raised intracranial pressure, and the hypoxia puts those patients at greater risk of vision loss. Looking at sleep apnea, particularly in men, we've got several cases showing that treating the sleep apnea alone is enough to resolve the intracranial hypertension. And in a comparison of men with IIH compared to controls, the IIH patients were much more likely to have a positive Berlin questionnaire, which is one of the screening tools for obstructive sleep apnea. This is a new study which is on an all-female cohort where they looked at patients who are under either bariatric surgery or community weight loss with their IIH. And of those patients that had obstructive sleep apnea, the stop-bang questionnaire was the highest sensitivity. And I'll go through that and show you how you can use that in your patients. We know that the obstructive sleep apnea patients did significantly worse with their IIH, even though they had no difference in their baseline characteristics. The sleep apnea patients had much poorer outcomes at 12 months with relation to the lumbar puncture opening pressure, the optic nerve head volume, and the mean visual field deviation. And what was interesting, if you improved the obstructive sleep apnea measurements, they had improved papilledema, independent of their weight loss, and improving AHI correlated with falling raised intracranial pressure. So treating the sleep apnea resulted in improvements. So when should we definitely look for sleep apnea? I certainly think men with IIH. If there's vision loss or papilledema that's out of keeping with the other clinical findings, obviously if they have concurrent clinical signs such as floppy eyelid syndrome, which is leaning you to thinking that they have sleep apnea, and really an argument could be made to screen every IIH patient for obstructive sleep apnea, given that we know that they have worse visual outcomes down the track. So what are you going to do in your clinical practice? And I would strongly recommend that you apply the stop-bang questionnaire to your patients. It's a very quick and easy thing to do. We ask about snoring, daytime tiredness, observed apneas with their partner, high blood pressure, a body mass index of over 35, an age of over 50, a neck circumference of over 40, and a male gender. And you can then score this, and then depending on whether the patient is low, intermediate, or high risk, they then go on to be considered high or low risk for obstructive sleep apnea, and you can then refer them on to formal diagnostic testing and treatment. So really, in conclusion, should you ask about obstructive sleep apnea and perform a sleep study in those patients with NAION? Absolutely. I think there's no question about that with NAION. IIH, I think it's really useful to do the stop-bang questionnaire and send those patients on with who are high risk for further study. Thank you very much.
Thank you, Dr. Claire, for a brief review. And may I now invite Dr. Elsie Chan to speak to us about keratoconus? Is she on the...
Yes, I'm here.
Okay.
Sorry,
yeah. There you go.
Sorry, I just had to wait to share my screen. Yep, can you see that all right?
Yeah.
Great, thank you. So thank you so much for inviting me to be part of this symposium. And I've chosen the topic of keratoconus because I feel that keratoconus is still a really undiagnosed condition. So I wanted to share with you some of the most important points about keratoconus, and in particular, epidemiology and prognosis after cross-linking. So keratoconus is actually much more common than people realize. There have been a number of prevalence and incidence studies published in the literature that range from different countries, 1 in 375 in the Netherlands, 1 in 2,673 in South Korea, to 1 in 191 in New Zealand. Each of these studies have suggested there may be differences between different countries, but at the same time, there's also a different methodology employed to determine the prevalence. So I've been very lucky to have access to an amazing study called the RAIN study, which is based in Perth in Western Australia. And this is a multi-generational longitudinal cohort study, one of the largest pregnancy cohort studies in the world. And in 1989, pregnant women and their newborns were recruited for this study. And we've been fortunate that after all these years, those children have now turned 20 and 28 years with time, and they've had shine plug imaging performed at these 2 time points. And so when we looked at the prevalence amongst the 20-year-old adult when they turned 20, we found that the prevalence was 1.2%, which equates to 1 in 84 of the participants. When these participants reached 28 years, we found that the prevalence was 3.4%, or 1 in 30, making an incidence of 2.2%, or 15 additional cases between 20 and 28 years. And this incidence and prevalence is one of the highest reported in the world. So my first learning point is keratoconus is much more common than previously reported. And I think those of you who do cataract surgery and do a lot of toric IOLs will also notice that when you perform corneal tomography or topography, this is indeed the case. So who should you be thinking about screening for keratoconus? I think it's important to remember that while we typically think of keratoconus having its onset in the 2nd decade of life, so when someone's a teenager after puberty, the youngest reported age in the literature I could find was 4 years, whereas the most youngest patient that I remember seeing in the last few years was this 10-year-old whose images you see here, where they presented with unaided visual acuities of 2/160 on the right and 6/60 on the left. And it's important to remember that children who are diagnosed at a younger age tend to have more severe disease on presentation and more rapid progression. So it's very important to diagnose them when they're young. In terms of the ethnicity, there is in the literature, it appears to be more common in those who are from an Indian or Pakistani background, who are Black, Hispanic, Maori, or Polynesian. We know it's more common in those who have a family history of keratoconus. And in a New Zealand study, they suggested that 1 in 3 people who have Down syndrome also have keratoconus. It's also associated with hay fever, eczema, and asthma in many studies, and allergic eye disease, eye rubbing, and as Professor Claire Fraser just mentioned, sleep apnea can cause multiple problems, and it's also associated with keratoconus. There's also biomechanical associations as well. One of the problems with diagnosing keratoconus, however, is that there's no consensus on the diagnostic criterion. And in addition, there are no signs in the early disease. So I recommend you screen your patients if they have risk factors for keratoconus, especially if they're young and they've got increasing astigmatism, or they've got decreased vision and a normal clinical exam. So how do you diagnose keratoconus? Corneal tomography remains the gold standard, where we look for posterior elevation, abnormal thickness distribution, corneal thinning. For those without corneal tomography, then using a retinoscopy, looking for a scissor reflex is also useful. And I think the future lies in machine learning. So my second learning point is screen children with risk factors. In managing keratoconus, there are of course two important aspects. One is to stop progression and the other is visual rehabilitation. And I'm going to talk about cross-linking and not going to talk about visual rehabilitation because of the time. So keratoconus can be managed with cross-linking to stop progression, as you all know. And in actual fact, this year represents the 20th anniversary of the first paper that was published on the use of cross-linking in clinical practice in 2003. So this many years on, we're starting to get more publications looking at the longer term follow-up of cross-linking. Looking at these 3 studies, which have been published with more than 10 years follow-up, the interesting thing is the keratometry values and the corrective visual acuities actually improved throughout those 10 years in most of these studies. Not unexpectedly, there are a few cases that progress. The stories are slightly different in the pediatric cross-linking population, whereas you can see from these 3 studies, it's quite amazing that the number of patients who stabilize, it was almost identical between the studies, between 76 and 79%. But this does mean that when you're treating a younger patient, the parents should be clearly informed at the time of cross-linking that 7 to 10 years down the track, treatment could potentially be repeated if necessary in nearly 1 in 4 of these patients. In Melbourne, we've been very fortunate. We published as many of you who follow the cross-linking literature, we published our randomized control trial of cross-linking many years ago now, and we've been performing cross-linking since 2006. So what I've done is I've invited some of those patients back to our hospital and tried to see whether they had been stable over this. Patients back from our original trial who've had follow-ups ranging from 7 to 13 years after their treatment. And looking at their results, looking at the the K2 value, which is the steepest keratometry and the steepest axis, we found that all of these patients have remained stable since treatment. There's been 1 retinal detachment following cross-linking, which I don't believe is related to the treatment. No cases of persistent haze or scarring. No patients have required a repeat cross-linking. And more importantly, no patients have required a transplant. With corneal transplants, I then decided to look at the number of transplants being performed for keratoconus in Victoria. And as you can see, when we started to perform cross-linking in 2006, over this period of time, I think we've got long enough to see a real downward trend in the cases performed for keratoconus. My learning points for you are keratoconus is more common than previously reported. Screen children with risk factors, and cross-linking is effective, but please monitor your pediatric patients for longer because they may progress. Thank you.
Thank you, Dr. for a quick overview about the incidence and situation of keratoconus. And as you rightly pointed out, it's much more common than what we always thought about it. I will now be speaking on from a very common disorder. We will now move to a not so common or a rare disorder. Just excuse me for a moment. So we'll be talking about Murren's ulcer. This is something which is first and foremost a diagnosis of exclusion. It's very, very uncommon, so it should not be the primary diagnosis. However, it is equally important to understand that it should be there in the back of the mind of every corneal surgeon whenever we see a peripheral ulcerative keratitis. So basic diagnosis would always be peripheral ulcerative keratitis, and only if we are able to exclude most other things, then should the label of Murren's ulcer be utilized. So how do we approach these patients who present to us? The approach essentially, as I mentioned, should be that the primary aim or the primary diagnosis would be to see if the peripheral ulcerative keratitis fits into the picture. And for this, we have to always look into doing an aggressive systemic evaluation. It would never be, I would be failing if I did not emphasize that aggressive systemic evaluation in every patient of peripheral ulcerative keratitis is very, very important. It can make the difference between life and death, literally in some cases. So if there is no finding on an aggressive systemic evaluation and the adjacent sclera is not involved, then the patient can be labeled as Murren's ulcer. So other than PUK, what are we looking at? It is important in various situations for infectious keratitis as a possibility. Now, infectious keratitis would have certain presenting features which are beyond the discussion of this particular talk. But infectious keratitis should always be kept in mind if there are atypical presentations, which we see in these cases. We'll come to the typical presentation of a Murren's ulcer in a minute. Other than that, it is very important to look for collagen vascular disorders, primarily rheumatoid arthritis, polyarthritis nodosa, Wagner's scleromatosis, and various other collagen vascular disorders. In polyarthritis nodosa, it can be the difference because these kind of patients can have very severe systemic presentations. And importantly, these corneas can perforate within 24 to 36 hours. So that is very, very important to understand. And that's the reason why we mentioned that a aggressive systemic evaluation in all these patients is mandatory. It is believed that Murren's ulcer is autoimmune in origin and has both cell-mediated and humoral arms which are involved. However, this is not really very well understood. It is also believed to be a localized autoimmune reaction to the corneal tissue. So antibodies being produced against the tissue is the belief. However, there are other concepts which have been brought forward, like in some associations with trauma have been mentioned, local infections like herpes simplex, or in systemic diseases like helminthiasis and hepatitis C, some association has been shown. But whether association means a causative inference is a matter which is open, but it is unlikely to be the case is what most of us would feel. So characteristically, it is an ulcer which progresses slowly. Now, this is a question, slowly means what? Because it depends on at what stage the patient appears to you in the outpatients. So a slowly progressing ulcer, which is circumferentially moving and deeper towards the center of the cornea. The key which we feel in Murren's is important is to see the overhanging lip of the ulcer. In fact, it would be interesting that if you try to use an instrument and go in and see how far you can go in before you can meet any resistance in the tissue, you'll be surprised at the extent of damage that this particular ulcer can cause, even though you feel that the tissue is quite okay to look at clinically. These patients can do well if treated appropriately, and that's what we come to next. So, as we mentioned, systemic workup for collagen vascular diseases is mandatory in all patients. Now, this is something where there are two ways of looking at it. If we work in a large institution and we have the backup, it can be done in-house. Alternatively, for people who are in private practice or in smaller setups, it might be useful to take the support from an internist or a rheumatologist to do an elaborate vascular workup. Local evaluation, as I mentioned, overhanging edges is a very classic presentation, and that is almost pathognomonic of a Murren's ulcer. Now, the key here is to understand what would be the scenario depending on whether the presentation is unilateral or bilateral and or what is the given age of a patient. What has been seen over the years is that a unilateral version is usually benign, less aggressively spreading, and can be managed with topical medications in a large number of patients. Bilateral disease, or what is also known as atypical, or in some parts of the literature, it is mentioned as malignant Murren's ulcer. It's a very, very aggressive disease, rapidly spreading, and it can also lead to loss of sight because of corneal melting and perforations if not adequately addressed. So how do we manage these patients? There is the medical line of management, and there would be some surgical adjuncts also, though surgical therapy is an adjunct to systemic or topical therapy is what I believe. Essentially, intense topical steroids. Now, this is something which is important because many a times there is a delay in initiating topical steroids because of the inability to differentiate whether it is an infectious keratitis or otherwise. So that is an important call which needs to be taken. Intense topical steroids in some patients, if there is a unilateral presentation, intravenous methylprednisolone might be used to set up the system or immunomodulate the patient. Along with this, we have found it useful to do conjunctival resection, do a superficial keratectomy so that you can scrape off all the necrotized or dead tissue. Once that is done, a thin layer of cyanoacrylate adhesive applied extending beyond the edges of the ulcer. Now, this is very critical because what we have seen is that if we leave some part of the area unattended, then that can become another leading edge and can continue the progression of the disease. So cyanoacrylate adhesive is important to be spread, go beyond the edges of the ulcer. And top of this with a bandage contact lens. And these patients then need a very close follow-up, because with the amount of cyanoacrylate adhesive and the inflammation, it becomes difficult to differentiate between pure inflammatory reaction and the infections, if any secondary infection creeps in. In cases of bilateral Murren's ulcer, all of the above, in addition, systemic immunosuppression becomes very, very important, because without systemic immunosuppression, most of the bilateral or the aggressive Murren's ulcers are not going to do well. This is something which is very, very crucial to understand, that being ophthalmologists, many a time we feel that topical medications should do the trick. It does not work in cases of bilateral Murren's ulcer. Even in a case of unilateral Murren's ulcer, what I have seen is that if it is showing any kind of a recurrence, then it is important to bring in systemic immunosuppression, because it's evident that the primary treatment has not succeeded in arresting the disease completely. The take-home message from this for all of our attendees are that all of these patients, to my mind, require the support of an internist or a rheumatologist, because the extent of assessment required for collagen vascular diseases as coexisting problems is something which is very important. And as I mentioned, recurrent unilateral or presenting bilateral diseases definitely need both a workup as well as systemic immunosuppression. In both the cases, the role of a rheumatologist or a very good internist cannot be overemphasized. Thank you for attention. And may I now invite Dr. Vinay Gupta to talk to us about artificial intelligence and management of juvenile glaucoma. Dr. Vinay?
Yeah, thank you.
Just give me a minute, sir. Yeah. Dr. Vinay Gupta?
Yeah, I'm here.
I can't see you. Yeah, I can see you, sir.
Yeah. So I hope my my screen is visible now.
Yes, your screen is visible, sir.
Thank you. So basically, I think I'm going to talk about glaucoma, which and particularly juvenile glaucoma, primarily because it's not so uncommon in this part of our world. So, so as I said, we do get to see a lot of patients of this disease, that is juvenile glaucomas, in India and in South Asia. And unfortunately, because it's not so common in the Western world, we don't know much about this disease. And since this happens in a socially productive age group where a lot of these patients are young, a lot of these people are someone's father, someone's son, someone's husband. So managing these patients becomes very important because it's a very socially productive age group. And therefore, the economics of managing this disease is important. It's also important because the genetics of all the glaucomas actually began with this subgroup of diseases, which was the juvenile glaucomas. So as I said, in our part of the world, we see at least about 3 to 4 such patients for every 100 new glaucoma patients that we see, which is much larger than what is there in the Western world. And if you see our population structure is such that a lot of us are in a young age group. So if you take the numbers, there are very large numbers that we have to deal with. So what is known in literature is that it is an autosomal dominant disorder, which is associated with very high intraocular pressure, a very concentric deep cupping, which leads to a generalized visual field loss and a lot of disability at a very young age. So this is how the patients present to us. They present with very deep, steep cups at a very young age when the visual fields may not be so bad. But at the other end of the spectrum, we have patients presenting at a later age with the same kind of cupping, but with a very severe visual field loss and very high intraocular pressures. So what we described gonioscopically while we did gonio-photographs of a lot of these patients, we found that there is some amount of dysgenesis of the angle in the form of a high iris insertion, or an angle which is absolutely featureless, which is caused by the trabecular beams being extremely thick and compact, so much so that they gave the appearance of ground glass appearance, which Barkan described as a membrane. And if you histopathologically see this trabecular meshwork, it actually appears like a membrane. And then there are others where there are mixed kind of features, gonioscopic features. And finally, then there are about a third of these patients which have absolutely no gonioscopic abnormalities and are just normal primary open angle glaucomas. If you see, almost 2/3 of these patients will have some amount of angle dysgenesis. And we did ASOCT, very high definition ASOCTs of these patients. And you can see this membrane kind of a structure here at the angle, which was seen in a lot of these patients who had abnormalities of the angles. And sometimes you can even see them in a unilateral case of juvenile open angle glaucoma too. They present in a very different way. These are all anterior segment photographs of different patients with juvenile open angle glaucoma. See how the iris looks in all of these patients. See the prominence of the crypts in these particular patients, unlike the upper two irises where the crypts are not so prominent. So basically, they're not all alike, and unfortunately, as I said, we do not know much about it. What is written in literature is anything which is open angle less than 40 years is to be labeled as juvenile open angle glaucoma, but then they're not all the same. Therefore, we used artificial intelligence, we used cluster analysis to kind of classify these patients into different clusters based upon their gonioscopic appearance and their iris features. And we found that they formed 4 clusters, basically. Those which were associated with a normal looking iris and a normal angle, those which are associated with some dysgenesis in the form of immature angle. And then there were those who had a normal looking iris, but a very high iris insertion. And finally, we found this particular cluster, which had a very prominent crypts of the iris and a very high iris insertion. These were the ones which presented with a very high intraocular pressure. Almost 70% of these juvenile glaucomas had intraocular pressures above 50 millimeters of mercury. So this leads us to the genetics, because there are different kinds of juvenile open angle glaucomas, and unfortunately only 30% could be explained by the myocilin gene. The myocilin was the first gene for glaucoma that was discovered, and it was discovered in a family of juvenile open angle glaucomas where a large number of these people were affected with the disease. And even in myocilin, there are certain mutations which are associated with a more severe kind of disease compared to the others. So when we looked at our data of juvenile glaucomas of more than 300 families, we found that actually there were not so many were autosomal dominant. In fact, most of them were sporadic cases. So this was interesting because this brings us to other genes which could be involved. And when we screened them for myocilin, we found that myocilin, as is known, was present only in 30% of the cases. And in some patients, there were CYP1B1 mutations also, which means that we need to look for other genes that are associated with this disease. Now, because this glaucoma happens at a very young age, you need to distinguish it from pigment dispersion glaucomas, steroid-induced glaucomas, congenital glaucomas that can spill over and appear as juvenile glaucomas. Patients with trauma sometimes will have very high intraocular pressures in one eye. Sometimes certain uveitic glaucomas, which are extremely very silent, looking like Posner-Schlossman, could be mistaken for juvenile glaucoma. Sometimes primary angle closure glaucoma in a very young age, unless you do a gonioscopy, you will not be able to differentiate it from open angle glaucoma. Then there could be cases of axon field rigor, which are very subtle forms of axon field rigor that need to be distinguished from juvenile open angle glaucoma. There could also be patients who have been born prematurely and have very large cupping. They can mimic a juvenile open angle glaucoma also. And then there is a subgroup called the juvenile normal tension glaucomas also, which have just normal tensions and cupping with visual field effects too. So all of these need to be distinguished before you actually diagnose them. As far as management is concerned, a lot of people think that because it happens in young age, so surgery is the mainstay of treatment, but almost 2/3 of these can be managed medically actually. Regarding laser trabeculoplasty, it is controversial. Some people think it works, the other things they don't work. As far as surgery is concerned, there are different kinds of surgery, including the minimally invasive glaucoma surgery that are being propagated. But because these patients are presenting at a very young age, it's important that we do a surgery which is long-lasting, and trabeculectomy with or without mitomycin is still the gold standard and really helps to control intraocular pressure in the long term. As far as laser trabeculoplasty is concerned, we did it in a few eyes and we found that it does work in about 30% of the cases, and it's worth a trial. But it was those patients who actually had some amount of angle dysgenesis where the trabeculoplasty was not so effective, and therefore we published this where we found that if you do ASOCT and you can actually pick up angle dysgenesis on ASOCT, you can then say whether this particular patient is going to respond to angle surgeries, either SLT or any type of mixed surgeries. As far as trabeculectomy is concerned, the eternal question is to use or not use mitomycin in these young patients who are presenting with a primary open-angle glaucoma. After having followed up a lot of these patients over 10-15 years, we've realized that use of mitomycin really helps in bringing down the pressures and producing low diffuse blebs. As far as long-term follow-ups of these patients are concerned, actually they don't do so badly. In fact, 10% of them are only those who are going to progress. Majority of them maintain the good intraocular pressure, and the risk of perimetric blindness is also not very high, because a lot of these patients, when you bring down the intraocular pressure, the intraocular cupping, the glaucomatous cupping actually reverses. So unlike certain normal tension glaucomas, pseudoexfoliative or angle closure glaucomas, which progress extremely fast, the progression rates in juvenile glaucomas are not that bad when they are treated. But unfortunately, there are patients from low socioeconomic groups who actually present with very high pressures and blindness at a very young age, probably because they are not screened. This is not the age where you would screen patients for glaucoma. And unfortunately, there are about 10% that come to us which are bilaterally blind as well. And these are those patients who have very high intraocular pressure, and as I said, from a low socioeconomic group. So therefore, to summarize, I would like to say that there are certain features that we need to find out to distinguish which patients are going to do worse compared to the others. We need to properly classify them, as I have just tried to do so with our artificial intelligence. We are looking for genes other than the myocilin that could be responsible for a lot of these cases. And of course, we need better management techniques. We have this survey article if anyone is interested in reading about juvenile open-angle glaucoma. And we have concisely given all the latest updates on this disease. This is our team. We've been working over 15 years in this particular disease. And finally, those who are interested in juvenile or pediatric glaucomas, we have a society called the Indian Pediatric Glaucoma Society, which we invite you all to join. Thank you.
Thank you, Dr. I will now invite Dr. Ajay Arora, who will speak to us on suprachoroidal steroids in persistent macular edema. Dr. Ajay, can I?
Can you see my screen?
Yes, we can.
Okay. At the outset, I must thank Dr. Namrata, Dr. Lalit, and the entire organizing committee for this opportunity. I've been hearing wonderful talks, wonderful talk by Dr. Vinay. I'm going to talk on suprachoroidal steroids in persistent macular edema. No financial disclosures, a patent applied for the device. So basically, when we look at a macular edema, I'll be talking on persistent diabetic macular edema and non-infectious uveitis. So these are the various treatments that are possible in a diabetic macular edema: systemic control, intravitreal injection of anti-VEGFs, IVTA, intravitreal injection of Ozurdex, and for macular edema and non-infectious uveitis, we give topical and systemic steroids, and of course intravitreal triamcinolone or Ozurdex and immunosuppressives. So when we look at the various types of medications that can be given to the eye, so these are the various options that are available. And at this point, the best treatment available is intravitreal. But then there is a possibility of using the suprachoroidal space. The problem, the advantage of the suprachoroidal space, as you can see from this publication, which showed that when a latex dye is injected into the suprachoroidal space, it spreads to cover almost 50% of the posterior segment. That means there is a large area which, if a drug is injected properly in the suprachoroidal space, a large area gets covered and can definitely affect the posterior segment well. The problems with suprachoroidal injections are that it is a blind procedure in a potential space which needs a precise injection and needs a proprietary microneedle or a microinjector system. So it's been shown clearly the suprachoroidal triamcinolone in uveitis works extremely well. And these are the various options available by the ClearSight Biomedical, which is not available in our country at this point of time, where triamcinolone can be injected in the suprachoroidal space using the microneedle. And then you have an option of catheterization of the suprachoroidal space, which was made by Med1. It is not commercially available anymore. And you have the iTrack system, which is again being bought over by ClearSight Group. So this is the microneedle, and this is the normal 30 gauge needle. People have done a jugaad where they have made a microneedle with a 30 gauge needle and a 23 gauge needle. So what I looked at is it possible to inject the drugs with a commercially available 30 gauge needle using a specific device? Is it precise? Will it be safe? So we decided to construct a device which can use a 30 gauge needle. We did some animal studies on goat size and then did human pilot studies. And now we have 104 eyes in which this device has been used and suprachoroidal triamcinolone has been injected. So this is how the device looks like. And these are the animal studies. You can see here the goat side with a 30 gauge needle. A suprachoroidal triamcinolone is being injected. I'll dissect off the sclera to the superficial lamella of the sclera to show that we were in the suprachoroidal space. So you can see here this whitish material, which is the triamcinolone. We did the studies in animal eyes where we could demonstrate on a UBM triamcinolone, methyl cellulose injected, and the was injected in the suprachoroidal space and helone injected in the suprachoroidal space. So this is what we did with the same device in a human eye, where the 30 gauge needle is being used. And this is usually given either in the infratemporal or infranasal quadrant, or it can also be given in the supranasal quadrant. You can see that the area looks pristine clear, and there is the drug goes into the suprachoroidal space well. It does need some learning time. Just to show you some cases, this is a patient with a persistent diabetic macular edema who had received anti-VEGFs multiple times, intravitreal injection of Ozurdex. And there was a point in time in India when Ozurdex was not available. So this patient came to me. We had this option available. We got a consent from her. And this is what you can see here. This is pre-injection, pre-Skita injection. This is the 14th day. This is the 34th day, and this is the 70th day. So you can see a beautiful reduction of the macular edema after the suprachoroidal injection of triamcinolone. This is a patient of uveitis whom I had treated in 2014 with patient was treated with antituberculous treatment as well as systemic steroids. So when he came back, he said he doesn't want any systemic steroids because he had had a weight gain after the steroid treatment. We gave him Skita, and this is the result. His vitreous cavity cleared, his visual acuity improved. This is a patient of a non-infectious uveitis. You can see here there's a macular edema. She's a 56-year-old female, pseudophakic, both eyes with intermediate uveitis, with a visual acuity in the right of 6.9 and left of 6.36. We gave her a Skita injection, and the macular edema resolved and stayed resolved for about 4 months' time. Then we decided that can we increase the time duration for the action of the suprachoroidal steroid, and we went ahead and centrifuged the triamcinolone, and we removed the supernatant 0.2 ml of the centrifuge triamcinolone was used, which amounted to almost injection of about 16 to 20 milligrams of triamcinolone in the suprachoroidal space. So this is the same patient where suprachoroidal triamcinolone was injected, and it gave us marvelous results. The effect lasted for almost about 8 months, which is even Ozurdex is not able to give us that much of a reduction of macular edema for that extended period of time. She received a second injection after that, and the second effect lasted for almost 7 months. So in conclusion, suprachoroidal injection of triamcinolone with the suprachoroidal injection device is safe, effective, and cheap. It does have a little learning experience because you need to learn how to give it. It will become a promising treatment tool for non-infectious uveitis and persistent diabetic macular edema. Centrifugation has allowed us to extend the period of effectivity to almost about 7 months. It does need a larger institutional-based study with multiple users. So these are the various, it's an autoclavable device, and we can potentially inject even genes in the suprachoroidal space. We can, the needle costs only 2 rupees, so the cost is significantly reduced. So the take-home message is each one of us is an innovator. Let's jot down ideas and develop them, share your ideas with the like-minded people, join hands together and make in India possible. Thank you very much.
Thank you, Dr. Ajay. And definitely Make in India is possible. Many of us are witness to it, and you have added one more feather in India's cap. Excellent presentation. I think we are at the end of this session. May I request the chair to take forward this, or we close it if there are no questions?
Thank you, Dr. Vinay. Thanks for
it. Thank you, sir.
Thank you very much.
So we bring this session to a close, and we will now, I am told we'll be rejoining at 5:30 for the next session. Thank you, everyone who's been watching us. Thank you.
Hello.
Yeah. Hi, Dr. Liu.
Hello. Hello,
Hi, how are
Christopher.
you?
Dr. Mom.
Hi.
I got a text from Prof. Namrata to say that we're not starting for half an hour. Is that true?
I have received a mail. It has mentioned 2 times. One is IST 5:30 and one is 6 Indian Standard Time. But my previous knowledge was it is 5:30. That means you're 12.
5:30 is 12, is it?
Yeah.
5.5 hours.
Mm-hmm.
Anyway, so we've got a few people here. I think let's just see what I think Namrata say that we're going to start now.
Okay.
Okay, great.
Okay. So good evening, good afternoon, everybody. My name is Christopher Liu, and I am co-chairing this with Professor Bhagat Goeda and also Dr. Bazak. So let us start with my talk, which will be a 10-minute update on the management of persistent epithelial defects.
Hello, Christopher.
Hello, Prof. Namrata. How
Can't
are
hear
you?
Yeah. I think my volume was low. It's okay. No, we can't hear you, Christopher.
How about now? Can you hear me?
I can hear you now.
So I think other people can hear me. Is that right, Dr. Basak? You can hear me?
Yes, I can hear you.
Okay.
Can you all see my slides?
Yes.
Okay, so I'm going to give a few minutes updates on management of persistent epithelial defects. And my name is Christopher Liu. I'm co-chair and I work from Brighton in the United Kingdom. I have no declaration of interest, but huge thanks to Mehran Sarai Ganavati, this gentleman here, who reviewed 1,500 papers on the subject for me. So you're all familiar with what a persistent epithelial defect looks like. This picture is courtesy of Professor Claes Dolman. And you see that this area will refuse to heal, and there's heaped epithelium there. And sometimes there'll be some deposits on the stromal surface as well, making epithelialization more difficult. Sometimes there is reduced sensation, making healing difficult. So the definition of a persistent epithelial defect is the failure of re-epithelialization despite 2 weeks of standard therapy. The diagnosis is by detailed examination and history taking, paying really careful assessment of topical and systemic medications because these can have bearing. And attention to the patient's general appearance, the face, the blinking and the lids as soon as they walk into your consulting room. It's important to measure corneal sensation, assess the tear film, including tear production, and a full examination of the ocular surface, which means lid margins, lashes, distichiasis, eversion, including eversion of the uplids, and as I said, examination of dry eye, exposure, any stem cell deficiency, and any keratinization, including bulbar and keratinization. So the etiology is often multifactorial, including reduced sensation after infection, inflammation after surgery, and so on. Drug toxicity, especially topical drug toxicity, including toxicity from preservatives. So the management is determination of the causative factors, which are often multifactorial, and then addressing them. So lack of sensation and infection, especially with herpes simplex the simplex virus, and toxic causes are usually missed. So we must remember a whole list that we need to look out for when examining the patient. So I would advocate a stepwise approach to management, beginning with conservative treatment and progressing to more aggressive options if refractory. So there are actually many treatment options, and some of them I favor for personal reasons. Some others favor, maybe they're more used to it. So we'll go through them and see what's what. Supportive treatment, very important. So reduce topical medications and use unpreserved drops if possible, or ointment, because ointment is on the whole unpreserved. And also it stays on the longer period. The resident time is very long. Aggressive lubrication using preservative-free artificial tears, gel or ointment. And punctal occlusion, either temporary or permanent, and sometimes a low-dose topical antibiotic for prophylaxis of infection. If you have stromal abnormality, so for example, if the stroma is inflamed, it's not good for epithelial cells. If the stroma is coated, then it may need freshening with superficial keratectomy, either by laser or manually. For example, if you have a vernal plaque, then some people try and heal that with a lot of steroid drops, but often it would be necessary to remove the plaque either by laser or manually through superficial keratectomy. Then you have stromal ulceration, and stepping may not support epithelial growth, and some people like to use amniotic membrane transplantation, often multiple layers. So we'll go into a little bit further. Suppression of inflammation is very important, and basically we're talking about oral doxycycline for quite some time, prolonged period of time. So often we need to suppress inflammation with low-dose non-preserved topical steroids as well. Casicol is a sugar, and it was much talked about a few years ago, but it's not really used very much nowadays. Tassorrhaphy, there is almost no pigment epithelial defect, persistent epithelial defect, which does not heal with the tassorrhaphy. So what I would advocate is a temporary central tassorrhaphy. And for that, all you need is just a loop of nylon suture and 2 bolsters. And the beauty of this is that it still allows topical medication. You can apply the medication on either side of the central tassorrhaphy, and you can also examine the eye whilst prising open the eye and asking the patient to look left or look right. So I really do favor that. And after a small number of weeks, there's almost nothing which doesn't heal. So you've got the alternatives here. So this is very old-fashioned. It's not really used anymore. Botox, yes, you can drop the lid, but I don't favor this because the recovery after some time is partial, and the lower part of the cornea is exposed quite quickly, and therefore you don't really have full protection. Similarly, the modern tape splint tassorrhaphy, which involves asking the patient to look down, holding up the brow, and putting a stiff piece of sticky tape onto the upper lid, stiffening it so that it is incapable of opening. Again, is similar to Botox, that the lower part of the cornea may not be fully protected. So what about the use of contact lens? Remember, I think if there is not much moisture, then you have to think about not using a soft lens, because that actually sponges away the water and evaporates it. Now you can use a silicone hydrogel bandage contact lens to protect the epithelium from eyelid blinking, or you can even use a sealed scleral contact lens to retain epithelial hydration and protect the ocular surface from and any tarsal keratin. Blood product derivatives are very useful. So you have serum tears, which have many goodies within it, and they can come in different concentration. These are the different concentrations. They're all effective and they work very well. But of course, it involves drawing blood and then spinning it down and then storing in the freezer. So it's really quite a palaver. So the alternative The finger prick autologous method is quite useful, that you sterilize the fingertip and then you prick it and then put a drop of blood from your fingertip directly onto the eye. Now, what about platelet-rich eye drops? Well, these also work very well, but again, it needs to be worked on. And you see it healed within a very high percentage of healing within a small number of days. So how does platelet-rich plasma compare with autologous serum drops? Well, actually, there's higher healing rates of corneal epithelia with the platelet-rich plasma treated eyes. Now, this is the news on the block, and there's a lot of interest in topical insulin, basically prepared at concentration of 1 international unit per mil, and using that as eye drops 4 times a day. 80 to 90% achieve complete reepithelialization. The optimal concentration may be a little lower. And how do they compare? Topical insulin 1% versus autologous serum eye drops. Insulin was actually more effective. So you think, now we don't even have to take blood from the patient. So this is very exciting indeed. Amniotic membrane, I don't really favor very much because it involves surgery and it's expensive, and being translucent, you can't really examine the underlying cornea very well. And also the eye drops that you put in may not get to the area you wanted to get to very well. Now, if you use the in-office sutureless AMT like Procura, then the success rate may be a bit lower. Limbal stem cell deficiency, I don't intend to go here because it's a completely a big subject by itself. Do look for any limbal stem cell deficiency and treat accordingly as to whether it's unilateral. You can borrow some from the other eye, or if it's bilateral, then you have to think about things like AIOS described by Geetha, or Comet described by Professor Sotozono in Kyoto. So other surgical methods, epithelial debridement, so removing the inactive epithelium at the edges of the epithelial defect, conjunctival flap, so freeing up your conjunctiva and then pulling that over your cornea. Now, this will mean that the patient cannot see through the eye, and even more if you transplant buccal mucous membrane graft, then the patient cannot see. But again, this, like tassorrhaphy, is very effective, but this is kind of permanent because you cannot remove it once it's on. Corneal neurotization, a very, very involved procedure, taking a sensation from the eye and through a big nerve onto the side, which is denervated. So I just bring to you another novel treatment, apart from insulin, is this called cenegermin or oxivate, is recombinant human nerve growth factor. Now, I won't go through the details because there's no time, but I will show the slides. It's being recorded, so you can stop and review and read the papers if you want. So it is very effective, but of course, you can imagine the cost. I will summarize now. Determine etiological factors by history and very thorough ocular surface examination. Reduce topical treatment. Use unpreserved drops and ointment. Lubricate with unpreserved artificial tears, serum tears, insulin drops, temporary central tassorrhaphy. And then these are things, if you really need to, AMT, nerve growth factors, conch flap, Gunderson's flap, buccal mucous membrane graft, corneal neurotization. This really is very much a last resort. So thank you very much. And these are my emails if you want to contact me. So now, who do we have next? I need to...
I am the next presenter.
Ah, yes, Prof. Namrata, please start.
So thank you so much. And I would be talking to you about phacoemulsification in compromised corneas or in corneal haze. And there are no financial or proprietary interests. And I would be talking about the off-label use of air as well as trypan blue dye. So whenever you have a case of corneal opacity and cataract, the bigger question is whether to do a combined procedure with keratoplasty or to do a cataract surgery alone. And whether you would do a combined procedure or a cataract surgery alone would depend upon where is the opacity, whether it is paracentral or peripheral. And in most cases of central corneal opacities, you would either combine it with the DSEC procedure or a DMEC procedure or a full penetrating keratoplasty procedure. In all these cases, we generally prefer to put a monofocal intraocular lens. The keratometry video keratography is often difficult. So in these cases, we use a standard K. Biometry, either ultrasonic D scan or immersion scan can be done, but IOL master often is not possible in these cases. And of course, for the IOL power calculation, if you're doing a DSEC triple, you would account for the hyperopic shift. And likewise for DMEC, where only slight amount of hyperopia is aimed at. Now, this is the algorithm for cataract surgery with corneal opacity, just to show where you would do phacoemulsification alone. Sometimes you may have to do phacoemulsification with optical iridectomy, and sometimes first you have to treat the cornea with PTK and then do a phacoemulsification. However, for combined procedures, depending upon what level of opacity is, one can do a SALC triple, ALTK triple, DALC triple, DSEC, DMEC triple, or a PKP triple. This is our review article on phacoemulsification with coexistent corneal opacities, which we had published for greater details. Now, whenever the endothelium is suboptimal, for instance, Fuchs dystrophy with cataract, in those cases, one has to always see whether the visualization is good or not. If the visualization is good, one can do a phacoemulsification or cataract surgery alone, and then later on take a call for endothelial keratoplasty or triple procedure. But if the visualization is poor, then in those cases where corneal thickness is more than 650 microns and cells are less than 800, then a triple procedure is planned. When you're doing a phacoemulsification with the corneal opacities, it is important to know which half of the cornea is clear, because from one half of the cornea, one can do the phacoemulsification procedures. So just to give some examples, this is a case of ocular surface disease, chemical injury with cataract. And here, the trypan blue staining of the capsulorhexis is done. And as you are underneath that opacity, go through the rhexis in one go. Don't leave the edge of the rhexis underneath the opacity. This is followed by the hydro maneuvers, the nuclear emulsification, irrigation, aspiration. Always remember to put your red glow on, retroillumination on, otherwise you may forget to put this on. And then it is always good to suture, especially in cases of chemical injuries where the corneal thinning may be there. Now, this was a case of healed keratitis with dry eye. And this was a one-eyed patient which had an optical iridectomy too, and didn't want to undergo a corneal transplantation procedure because of infection after corneal transplantation in the fellow eye. Notice again, trypan blue staining is done. The incision is planned here because this half is absolutely clear. Capsulorhexis is being done, and when you are underneath that opacity, you have to go in one go. Do a little eccentric capsulorhexis because this is the area where you will see, and this is also the area where patient will see in the post-op period. Little eccentric phaco is being done here because the chopping and the formation of the crater would occur eccentrically here. The retroillumination glow is on so that there is a good contrast between the grayish fragments and the red glow that is present. And the second instrument is very important because the nuclear fragments, etc., may be camouflaged underneath this opacity, and you need to get it into your area of visualization. Phaco in situ, that means you emulsify, you eat, you emulsify, you eat. And that is mainly because the red glow gets better and better. And as the red glow gets better, the visualization improves. Now you can see the edge of the rhexis here, and the foldable intraocular lens implantation is being done. The patient doesn't obtain a visual acuity of 6/6, but does become ambulatory in the post-op period. Now, this is again a case of dry eye healed keratitis, followed by in a brown cataract. And here you have to expand your area of visualization because this is also a small pupil. And again, this half of the cornea is clear, and notice it's a very hard cataract, but essentially the same principles which I had discussed earlier would be followed. And eccentric phaco and phaco in situ, which means chop and eat with the retroillumination on, will be done. Now, this was a case of chemical injury where there is a white cataract. It is a graft with the sutures in, but still you have to do the white cataract because this is only about 3 months old and you can't remove the sutures. In such cases, whenever a pannus is there, it is always best to remove the pannus. And notice how clear the cornea becomes. And when it gets blurry, put a blob of viscoelastic. And as you put a blob of viscoelastic, for that split of a second, it will magnify and it will also become clear. So you can initiate your step and complete capsulorhexis as well as the subsequent procedures in this case. Now, this was a black and a white cataract. A white cataract because of the opacity, and black because it was tattooed, and there's a synec here which has to be released. And again, your area of expansion or area of visualization has to be expanded. Just as you see the rhexis which gets lost underneath this haze, one can also pick it up from the intraop OCT microscope. And again, the principles of nuclear emulsification will remain the same. You do it from one half, and as you put the intraocular lens, in fact, the visualization becomes better and the opacity looks smaller, although it's easy to do when it's difficult to do when you're doing it under the operating microscope. And in this, the pupil is also enlarged. And followed by this, in the table itself, we would inject pilocarpine to see what is the state of the pupil, because that is the area which will remain in the post-operative period also, from where the patient can visualize. In cases of Stevens-Johnson syndrome, we've already published our results, and these are cases which are high risk, and you cannot do a corneal transplantation in these cases. So here, again, the nylon hooks are used. It's a temporal incision. The endo-illuminator is put inside the eye to see where you have to chop. And now it is put outside the eye to see where you have to put the intraocular lens. And these cases also, again, will not get 6x6 vision, but the patients would become ambulatory. So this is just to show some of the results from the cases that we encounter for chemical injuries as well as for Stevens-Johnson syndrome. So visual acuity is 20/40, but then it makes them ambulatory, and these cases are high risk for grafts. So those problems of high-risk grafts are obviated. Then I think femtocataract also has a role to play in corneal haze. It doesn't completely allow you to do a complete capsulorhexis or allow you to do chops in all the quadrants, but it does soften the nucleus. And then there would be fill in the blanks sort of areas which can be dealt with more amicably. So just to show a case of corneal haze where rhexis is initiated with the femtosecond laser. And notice it's not complete here, but then you just have to fill in the blanks, in the sense you have to just join these areas, and chops will be present at other areas, but not in this area. But then it helps you to, again, do the surgery, because pre-formed chops are already there. And after doing irrigation aspiration, one can do an intraocular lens implantation, and everything becomes more clear once you implant an intraocular lens. Now, this case was in fact not planned for a corneal cataract surgery, but here DALC was being planned and a cataract was noticed. So cataract was also dealt in the same sitting. We've not reached up to the desmoids, but there's a little bit of stroma already onto the surface, and the cataract surgery is now being done. And after doing the cataract surgery, just as one would do routinely, foldable intraocular lens is put, and then the last layer just above the desmoids is removed, followed by the graft, which is then placed onto the surface. So this is again the post-op picture of the same patient. Now, this was in fact referred for penetrating keratoplasty, but this was a Fuchs dystrophy with cataract. So we removed the hypertrophic epithelium. Then the scarred desmoids membrane was removed and a desmotorhexis was done. Subsequently, the anterior capsulorhexis was done. So this was like a 3 rhexis in one. And then phacoemulsification was done, followed by foldable intraocular lens implantation. Here, you can be a little more liberal, because even if you are onto the cornea, it doesn't matter, but it shouldn't cause a rent in these cases, because that can be a disaster. And this was followed by a DSEC surgery, which was done, and air bubble was instilled. And over a period of time, it does clear up. And this is the pre and the post-op picture of the same at 5 years follow-up with good results. And I come to the last part, which is a DMEC triple. And here again, the desmoids membrane is being removed to form a DMEC graft. Cataract surgery, which is being done, which we would do routinely. And then the desmotorhexis is done just as is advocated for routine DMEC procedures, followed by the graft, which is taken into the injector. is placed inside, and then you get the configuration of biceps curl upwards here. And once you get the biceps, now this is upside down graft because it's not biceps curl upwards. This is the correct configuration, and you inject the air bubble. So this is the post-op picture, 6x6, and this is at 1 month, where very faintly you can see the graft on a slit lamp. So to conclude, for high-risk cases, phacoemulsification should be done first. For good prognosis for grafts, combined procedures can be done, and you need everything. Your incision placement should be correct. The operating microscope should be good. You should have retroillumination on, nylon hooks, optical iridectomy, trypan blue dye, BSS plus, dispersive OVD may be required. Eccentric creta, eccentric rexes may be required in some cases, and keep all your fluidic parameters low. Of course, counsel the patient that ambulatory visual acuity is what we may aim for in some of the cases, and not exactly at a visual acuity of 20/20 or 20/10. Thank you very much for your kind attention.
Thank you very much, Prof. Namrata. Wow, what brilliant surgery. It is absolutely amazing. Dr. Bazak, would you like to introduce Dr. Geetha Iyer? Please unmute yourself, Dr. Bazak.
So now I welcome Dr. Geetha Iyer from Shankar Nethralaya, Chennai. She will be speaking on updates on keratoprosthesis. Dr. Geetha, please.
Thank you, Dr. Basak. I hope my slides are visible.
Yes, yes.
Let me thank AIOS and RCOF for this opportunity to present my talk on a broad overview of keratoprosthesis. I have nil financial interests to declare. So in this perspective on keratoprosthesis by Professor Liu, his introduction emphasizes on the long history of passion and perseverance by our predecessor ophthalmologists to invent a suitable keratoprosthesis device. Though we are still far from the quest of an ideal keratoprosthesis, my talk will revolve around the K-pros that are commonly performed and have stood the test of time. As we all know, keratoprosthesis forms the last resort for bilateral corneal blindness, especially in eyes with end-stage ocular surface disorders, and in those at a high risk for conventional penetrating keratoplasty. I like to liken the components of a keratoprosthesis with that of an intraocular lens, as in constituting of a central optic and a support system, which in turn consists of a haptic as well as a covering tissue. By default, the visual optic across all the keratoprostheses that are currently in use is an optical cylinder made of polymethyl methacrylate, and it is the support system that differs across the various K-pros and that defines and characterizes each keratoprosthesis that I shall be speaking about. We generally tend to categorize K-pros into type 1 and type 2 K-pros, the details of which I shall subsequently discuss. So when we speak about type 1 keratoprosthesis, the prototype of which is the Boston type 1 K-pro, the optic is the PMMA central cylinder, and the support system here, or the haptic, is the corneal carrier graft and the backplate. And this is the final appearance of the eye that has the keratoprosthesis in situ. The other set of K-pros, which are grouped under the broad category of type 2 K-pros, basically differ in the support system that goes along with the visual optic. So when we speak about the modified osteoodontokeratoprosthesis, the haptic is the tooth and the covering tissue is the oral mucosa. In the Boston type 2 keratoprosthesis, the haptic is the corneal carrier graft and the backplate, and the covering tissue is the eyelid skin. In the osteo K-pro, it's the bone and the oral mucosa respectively. And in the earlier done Vintucci K-pro, it used to be the dacron mesh and the oral mucosa. Compare it with the type 1 keratoprosthesis that I already spoke about, with this being the final appearance of the different types of keratoprosthesis in C2, the Boston type 1, the OKP, and the Boston type 2 through the eyelid. These are the K-pros that I've broadly categorized under type 1 and type 2. In India, we do have the option of using the orokeratoprosthesis, which is the indigenous version of the Boston type 1, which is available for use and sale only in India. And among the type 2 K-pros, the ones that I've highlighted in green are the K-pros that are most commonly performed. It is important to emphasize here that the indications, the technique, and the complications of each of these groups is entirely distinct and separate, and it varies. And these are some of the issues that I will highlight through the rest of the talk. The indications for keratoprosthesis, especially when it is a type 1 K-pro, is quite clear. In the sense that the eye needs to be a moist eye with a good blink, with no exposure and no underlying immunological condition. And with the experience that the K-pro fraternity has had globally, we have agreed on the hierarchy of prognostic categories for type 1 keratoprosthesis, where the best prognosis is in those eyes which have multiple failed grafts, viral keratitis, aniridia, limbal stem cell deficiency, and silicone oil filled eyes, an indication that we had described several years back as a novel indication for keratoprosthesis. The picture here shows one of our longest patients retaining the type 1 keratoprosthesis at 15 years following the procedure with a visual acuity of 20/120. The guarded prognosis includes the pediatric cases and the chemical injuries, and the most poor prognosis is associated with the autoimmune conditions such as SJS and OCP, where we routinely do not recommend the procedure of type 1 keratoprosthesis, and it's indicated primarily for end-stage bilateral corneal conditions and end-stage bilateral ocular surface diseases where the eye is moist with no underlying immunological disease. Moving on to the type 2 K-pros, the set of K-pros. Here, these are keratoprostheses that are performed for end-stage bilateral ocular surface disorders with an underlying immunological condition, such as most commonly SJS or OCP, severe dry eye, severe corneal shortening, and those with lid deformities. So how do we choose the type 2 keratoprosthesis? As of now, the modified osteoodontokeratoprosthesis still continues to remain our first choice, our first go-to keratoprosthesis in these eyes, considering the fact that it provides a watertight epithelial seal, and the long-term anatomic and functional outcome of the MOKP is still considered the gold standard against which the outcomes of the other keratoprostheses are measured. The surgical technique of the modified osteoodontokeratoprosthesis was classically described as a two-stage procedure in the Rome-Vienna protocol by Professor Giancarlo Falcinelli. We added an additional stage as a preparatory stage to the osteoodontokeratoprosthesis that has been described by Professor. And this is a short video which will highlight the 3 stages that are performed over a period of 6 months. In the first stage, the eye is basically prepared in order to receive the lamina. The iris is removed, the lens is removed using a cryo technique. The limited anterior vitrectomy is done. Not all cases require a penetrating keratoplasty, but the eye is closed at the end of the surgery. It's the canine tooth that is harvested in the subsequent stage, which is then fashioned into a lamina. A central hole is drilled for it to receive the optical cylinder, which is then placed in a subcutaneous pouch in the contralateral cheek for it to develop its fibrovascular supply. The ocular surface is prepared and draped with the oral mucosa, which is harvested from the cheek and anchored to the recti for it to develop its blood supply. The 3 months later, the lamina is removed from the contralateral cheek and it is subsequently placed onto the eye after reflecting the oral mucosa and making a central trephination in the cornea into which the lamina is placed, and the mucosa is then reflected back over the cylinder, which is secured to the sclera using anchoring sutures. This is the final appearance of the eye, and this is the procedure that usually takes a few hours over 3 stages over a period of 6 months. This was an article that we had the pleasure of writing with Professor Liu as the lead author as to decision-making and an algorithmic approach in the absence of tooth and deciding on the choices of Boston type 2 keratoprosthesis or the osteo-K-Pro in patients who did not have a tooth. The Boston type 2 keratoprosthesis, on the other hand, unlike the OKP, is a single-staged procedure where this is again a short video that highlights the procedure, where the initial part involves removing the entire conjunctiva of the bulbar and the palpebral surface, followed by the assembly of the keratoprosthesis, which is very similar to how a Boston type 1 K-Pro is assembled. The only difference being in the keratoprosthesis itself, which has an anterior extension in the form of a nub in the type 2, which allows accommodation of the eyelid skin. So once the keratoprosthesis is assembled, the host cornea is trephined and the lens is removed. The keratoprosthesis is sutured in place like a penetrating keratoplasty. And it is always combined with the placement of an amid glaucoma valve and a pars plana vitrectomy, which is classically termed as the kitchen sink procedure. And the procedure is completed by doing a meticulous lid closure around the central optic to ensure that the optic protrudes out through the skin. The decision making with respect to the choice of the various K-Pros depends on patient-related factors, because here, apart from the ocular factors, we would also need to consider the systemic factors that allow feasibility for general anesthesia, the oral and the dental health, and most importantly, realistic expectations with respect to the cosmetic outcomes in these procedures. Another deciding factor is also surgeon-related, which depends upon the training of the surgeon and the setup that the patient has access to, which allows him or her to have a multidisciplinary approach that is required for these keratoprosthesis. And the fact that these are procedures that are more than one staged as far as the OKP and the osteokeratoprosthesis is concerned, and you would also require the presence of an oromaxillofacial surgeon for these surgeries. The follow-up protocol for all the keratoprosthesis is quite well defined, very stringent, and focuses on and emphasizes upon the need to monitor the intraocular pressure, which in most of these eyes is done with a digital tonometry, to monitor the disc and the macula. And in the case of a type 1 keratoprosthesis, utilizes an indefinite use of topical 4th generation antibiotics and steroids, and the need to change the bandage contact lens once every 3 months. The OKP also involves the evaluation of the lamina by means of a spiral CT scan to look for the evidence of any laminar resorption in these eyes. Well, complications are the norm rather than an exception in these eyes with keratoprosthesis, and these can be broadly categorized into ocular complications and keratoprosthesis-related complications. Glaucoma is the most common comorbidity that we see in patients with chemical injuries, but needs to be assessed and looked for in all eyes that undergo K-Pros. Sterile vitritis and laminar resorption is something that we see more commonly in patients of Stevens-Johnson syndrome. Periprosthetic tissue loss is probably one of the most important complications that we see, in patients of keratoprosthesis. A graft melt, which is seen in a type 1 keratoprosthesis, a type 2 keratoprosthesis, which can cause a sudden hypotony and can also be the reason for an infection. This is a periprosthetic tissue loss wherein the laminar resorption is seen. The tooth has undergone resorption, and this is similar to a graft melt that occurs in patients with a type 1 or a type 2 Boston keratoprosthesis. Endophthalmitis is a devastating complication, but if well managed, these eyes can be salvaged and a re-keratoprosthesis can be done for visual recovery in these eyes. Mucosa and skin-related complications are seen in the type 2 keratoprosthesis, which need to be addressed aggressively and judiciously. This was a review article that we had published in the Indian Journal of Ophthalmology in 2018, which gives an in detailed understanding of the technique, the indications and complications that are associated with each of the keratoprosthesis. And this was a recently published analytical review of the evolution of the modified osteoodontokeratoprosthesis and the long-term visual rehabilitation in these eyes across various centers. There were several lessons that we have learned through the course of our K-Pro journey, and some novel concepts that we have been able to apply in terms of a new method of grading of laminar resorption, the novel use of bone morphogenic protein to salvage the lamina in eyes with laminar resorption, the technique of bone augmentation to delay resorption, and the technique of keratoprosthesis exchange in eyes with complications. The Lux keratoprosthesis was a multicentric study that involved the use of a K-Pro with a titanium sleeve and flange for better biocompatibility. And however, this is not something that is currently available. And another modification that we have adopted in some of these eyes that do not have good lids or require a through the mucosa keratoprosthesis is to use the Boston type 2 K-Pro through the mucosa. So the journey has been one where across the globe, the K-Pro fraternity has been trying to modify and innovate in order to improve the outcomes in these patients of K-Pros. But the future still demands that we have better IOP measuring systems for these patients, probably a synthetic OOKP that would make the surgery much more simpler, biosynthetic keratoprosthesis, and improved designs to further reduce the risk of infection, improve biocompatibility, and IOP monitoring in these eyes. Our experience at Shankar Nethralaya began in March 2003, and this was what we had published in the 2018 paper. However, as of today, the number of K-Pros that we have done stands at 350, close to 350, with more than 125 OKPs and 50 Boston type 2 keratoprosthesis, where our functional and anatomic outcome has been on par with the published outcomes. To summarize, K-Pros do form the last resort for end-stage corneal and ocular surface disorders. These are meticulous and time-consuming procedures that require lifelong follow-ups for the life of the individual or the life of the keratoprosthesis. These are surgeries that require a multidisciplinary approach. And since we do have the option of all the keratoprosthesis under one roof in our practice, we do also understand the importance of not just choosing the appropriate patient for keratoprosthesis, but also choosing the correct keratoprosthesis for every patient. And most importantly, keratoprosthesis surgery are life-transforming surgeries where you could definitely visually rehabilitate these patients, especially when the management in the acute stage is done in a timely manner. These are some of our keratoprosthesis across various types. It's a panel that shows the outcomes over several years of follow-up, maintaining and retaining a good anatomic and functional outcome. And our patients, all these are patients who have taught us on the way, and we acknowledge all that we have learned from our patients, most importantly from all our mentors. It is a huge multidisciplinary team that works back here at Shankar Nethralaya across specialties, not just in ophthalmology, but across ophthalmology also. And I would like to acknowledge my colleagues, Dr. Bhaskar Srinivasan and Shweta Agarwal, who form the core ocular surface team at SN. And we are glad to inform that we offer a 3-month short-term ocular surface fellowship for those who would be interested in the subject. And I also take this opportunity to invite you all to the 4th OSCON to be held between the 25th to 27th of August, 2023. With this, I thank you all.
Thank you, Geeta, for excellent overview of all types of keratoprosthesis. And nice to hear from you the extent of your experience across all types of keratoprosthesis. Thank you very much.
Thanks, Dr. Vasu. Thank you.
Thank you, Dr. Geeta. That's absolutely amazing. And how you summarize 30 years into 15 minutes. I think only you can do that. All right. So now we move on to the final talk for the first hour, and it's Professor Keith Barton. And he is a very, very old friend of mine. And many people call him the glaucoma tube king. And I think he kind of is a king on the glaucoma tubes. And Keith, can you please tell us, I think this follows on very nicely because all keratoprostheses more or less have glaucoma problems. So please take us gently onto the subject of glaucoma drainage devices. Keith, please.
Thanks very much, Chris. Can you hear me?
Yes.
Yes, okay. Yeah. Let me just share if I can find the share button. Can you see the screen?
Yes.
Okay, so talk briefly about tubes and their evolution. Really, I was interested to hear how you use the amide valve regularly with keratoprosthesis. I've always wondered, and I know the amide valves, from a surgeon's point of view, it's less challenging to put in, but it often doesn't give the best long-term pressure control. So I just always curious about that. My main financial disclosure really is that I co-designed the Paul glaucoma implant with Paul Chu and others at the National University of Singapore. When I started doing tubes, there were a couple of mantras that I felt were really tube myths. The first is that after 10 years, the corneas all fail. And here's a patient that I videoed in February last year, has got two tubes, a double plate Maltino put in the 90s, and infratemporal Barvelt in 2002. So this patient had two tubes more than 20 years ago in the one eye, and the cornea is still clear. So, okay, you may say that's an isolated example. Here's another one. This patient has got primary angle closure, which is the hardest really to tube successfully without damaging the cornea because the anterior chambers are small. And 20 years after implantation, the cornea is still clear. My feeling back then and now was that corneal failure from tube surgery is not inevitable, and a significant proportion, although not all of it, is technique related. If you put the tube in the cornea, you will damage it. The other myth was that you don't get low pressures. A successful tube is a pressure of 21 or 23 on two medications. And that's not true either. This bilaterally aphakic aniridic is a good example. I put these tubes in his eye when he was 15 years old. And he comes to see me once a year from overseas. And while the tubes are a bit longer than I would ideally have, they're well positioned, clear of cornea. They're 9 millimeters mercury in each eye. One eye is on COSOP, the other's on nothing. And what got me started on tubes was actually this randomized clinical trial that actually showed that at 5 years with a 350 Barvelt, you could expect to have a pressure of 13.7 on one medication. So that was rather better. That 13.7 on one medication was rather better with a 350 Barvelt than this kind of mantra at the time in the late 90s that you didn't get low pressure with tubes. The final thing that really sold tubes to me is this other myth that is still perpetuated regularly today, that all glaucoma surgery is time limited and you need to do one thing and then have something else that you can do later and then something else you can do later. And this is really perpetuated by people doing procedures that are not definitive, that procedures that are never going to control the pressure enough. And there are, as opposed to pressures that will, and there are procedures that will. So the idea you always need something in reserve, I think, is a myth as well. So Maltino really started the modern wave of implants with the Maltino implant in the late 60s, early 70s. And the idea that a permanent sclerostomy that cannot close is what many people think an implant is, and they miss the other important points, that equatorial drainage is important, that you need to get the plate close to the equator because the fibroblasts are less aggressive back there than they are more anteriorly. And I say people putting plates in far too anteriorly. And that the plate size is important and the plate characteristics is important to prevent external obstruction. But it's not just the size predetermining the bleb surface area, but it's the biocompatibility characteristics of the plate that are very important, that make some work better than others. But initially, there was a high risk of complications from early hypotony with the Maltino, and the long-term pressure control wasn't good. But that, with evolution of tubes, this improved. The Ahmed valve, to some degree, fixed the flow control problem, but it didn't really deal with encapsulation very well. The Barveld implant, on the other hand, was very good at preventing encapsulation, but you had to be a high volume expert to get the flow control right, and even then it was tricky. The Barveld implant appeared in 1991. The Ahmed valve appeared in the mid-90s. We're dealing here with 30-year-old technology, and there's been very little evolution of tube surgery since then, or of any sort of glaucoma surgery for the more advanced glaucoma surgeons. And tube comparisons, if you compare the Barveld with the Ahmed valve, there were 2 randomized clinical trials in the mid to late noughties, that the ABC study that I was involved in, and the AVB study that was Ike Ahmed, Paul Harasimovich, and James Tsai, and a number of others. And they both showed the same thing. Barveld, better pressure control. Ahmed's more forgiving and easier to get right. The pooled 5-year results accentuate these differences. At 5 years, the Barveld is achieving significantly better pressure control on significantly fewer medications, which I think is what everyone expected. With a pressure of 16.4 for Ahmed valves on 2 medications after 5 years is rather less impressive than the 13 and 1.5 medications that the Barveld achieves. And that's why many of us who deal with the more challenging glaucomas will use the Barveld. The Ahmed valve just doesn't cut it. Tubes have versatility, and that's a big reason for using them. They will work, whereas a trabeculectomy can work brilliantly in a patient who's a low risk factor for failure in a virgin eye. A Barveld implant will work to some degree in almost anybody, whereas you cannot say that of a trabeculectomy. These eyes, you might say, are untrappable. These scleral buckles, we don't see so many of these days. And you can put a Barveld behind a buckle. You can put it on top of a buckle. There are options. You can use them in eyes where CPC is almost impossible. Well, you can't do a CPC here, you can't do a trab here, but you can still get a Barveld implant in with a bit of experience and technique. You look for the area with the best sclera, and you hope your videos work, and you just very gently work around the areas of thin sclera. You can use underlay patches to protect the thin sclera, and place the tube and put a regular overlay patch on top. And we've done these types of cases at many, many patients, especially rheumatoid arthritics, Ehlers-Danlos, osteogenesis imperfecta, all sorts of eyes where you couldn't do anything else. And these are eyes where you either couldn't do external filtration or it wouldn't work. The problem, though, with non-valve devices, although they work better, is flow control has always been a problem. And in the old days, and in many places, they still do a single ligature, but this is really quite a crude, unpredictable technique. And this is it on the left, where you have a single ligature, and when it rots, the pressure crashes, and you ride out a period of hypotony. We stopped doing this 21 years ago, really, and moved to a ripcord technique, which gives you a degree of titratability. And there are various modifications of this where you can do it through a tight entry site so that there's little flow around it, or you can put extra ligatures on it to prevent excessive flow. And then if you withdraw it, you can adjust the flow and you can take it out completely. I've used the technique of external adjunctive ligatures to give a little bit of resistance so that they can be lasered sequentially and produce a stepwise reduction in pressure. This obviously requires a high volume of surgery to have the experience and the technique. You can't be doing 1 or 2 of these a year and expect to get it right. It's not difficult, but it does require the experience of knowing what you can get away with. And this does give you much more predictable IOP control than after the signal ligature technique. And traditionally, we use the supermid suture to do this with a 3/0 nylon. More recently, I used 3/0 ethylon because it the supermids, there is some manufacturing variability, and we found the supermids were too tight. And this is a bar vault with an ethylon. You can see if you look out the back, you can see there's far too much flow here. So then you can put on a 10/0 nylon ligature and get the flow a bit less. And then the ligature can be lasered at the slit lamp without removing the ripcord. And then later, if need be, after several months, the ripcord can be removed. So what's the difference between the single ligature technique and this sort of multiple technique is that you've got a stepwise adjustment rather than all or none reduction in pressure. But it does require more intense follow-up and experience. There are some cases where you should avoid the 101/350 bar vault, certain types of uveitis. And in those cases, I'll do either 250, an amide, or a single plate Maltino, the eyes where there's poor ciliary body function. Problems with tubes really are plate encapsulation, predictability of IOP control, and morbidity such as diplopia, endothelial cell loss, and erosion. Diplopia is somewhat unpredictable, but tends to be, in my experience, related to conjunctival tenons adhesions and shortage of tissue rather than actual muscle problems. It's usually associated with muscle, assumed to be associated with rectus muscle obstruction in function by the tube plate. But when I've revised patients for diplopia, I've usually found the muscle's fine and it's nothing to do with the muscle. It's actually very tight tenons adhesions. So the challenges in shunts are really to put them in the right place, put the plate in the right place, put the tube in the right place. And that sounds like it's not rocket science, but it's badly done in many places. So you mustn't compromise your technique because of obstacles. It is essential to get the plate back like this, not like this. Firstly, they don't work if they're further forward because they encapsulate more aggressively. And secondly, you're more likely to erode. And thirdly, the patient doesn't like having a big red lump in the front of their eye. And generally speaking, when people get this wrong, it's because they haven't made a big enough peritomy and they haven't taken the time to make enough space. It's possible in almost anybody to get the plate in the right place with the right technique. And then you got to put the tube in the right place. And we showed in this 5-year prospective study that there's significant endothelial cell loss at 5 years, 36% centrally, 50% peripherally. And it's critically dependent on where you put the tube at the entry site. If you have the tube behind Schwalbe's line, away from the cornea, the corneal endothelial cell loss is halved with a bar vault. It's half of what it is if you have the tube straddling Schwalbe's line in the more traditional place. And people tend to put tubes in the peripheral cornea unwittingly, thinking that if the tip is away from the cornea, they're okay. But that is not true. It is the entry site that's critical. And if you go, you can minimize that. In that study, there was only one patient at 5 years who actually lost corneal clarity. So the tip touching the cornea is important, but the entry site's much more important, and this is neglected. What about the sulcus? Well, this study from UCSF showed that sulcus does give you, fixation does give you less endothelial cell loss, but it doesn't give you less endothelial cell loss than putting it behind Schwalbe's line. It actually gave more slightly, but I think that's measurement error. But sulcus fixation, you do have to see the tip of the tube because it can get obstructed by vitreous. It can go, you can hit the edge of the IOL and go into the vitreous if you don't see what you're doing. It can get obstructed by iris and it can bleed a lot. So sulcus fixation isn't the panacea, but if you've got a previous PI, sulcus fixation is a good place to put it. Come in from the side, don't go through the trab. If you've got very small eyes, such as non-ophthalmos, and nowhere in the sulcus and no space in the AC, then you go into the vitreous cavity, but you do need a good vitrectomy. It's not good enough to say the patient previously had a vitrectomy. This was one that had a previous vitrectomy and still got blocked with vitreous base. You have to go behind. You have to get the vitrectomy surgeon back in again. The Paul glaucoma implant, which I've been involved in from Singapore, is a larger surface area. It's comparable to the Barvelt, but it's not quite as wide, and it's not quite as, but it is deeper from front to back. It's not quite as aerodynamic as the Barvelt either, but the theory is that there's more usable plate surface area than with the Barvelt because less of it's under the muscles. But it has a smaller tube, and this is really an evolution waiting to happen, and no one had just done it. It's only slightly larger than a PreserFlow. Which is, as we know, is minimally invasive. And it's a lot smaller than a Barvelt or an Amid. There's the Barvelt. And the Amid's actually marginally larger than a Barvelt, the tube in the eye. And, you know, this is important. Commercially available tubes are much bigger than they're required. They're redundant in size, 640 microns in diameter. Conventional tubes occupy the entire drainage angle and must rest on iris to avoid cornea. I get people saying that, you know, it shouldn't touch the iris. It has to touch the iris. If it's not touching the iris, it is in the cornea. And you do not get uveitis from a tube touching the iris. But it does kill endothelial cells. And a large tube in the corneal surface carries a significant risk of erosion. No matter what way you patch it or tunnel it, there's still a risk. A smaller tube in the angle should, in theory, result in less endothelial cell loss. And that one's coming in from the sulcus through a PI, and a lower risk of erosion. So this is really not rocket science. The smaller tube, however, has had an unexpected benefit, which we did not anticipate. The 6O proline that you can use to stent it, rather than the 3O proline required for the Barvelt, seems to give a more predictable outcome than we would have expected. I typically stent it all the way into the AC to prevent hypotony. And you can adjust this. It doesn't have to go all that way. But the critical bit is always to look for what's coming out the back, because you're going to get many fewer surprises if you know how much drainage is occurring. So many people just put the tube in and never look. So that's about right. That kind of slow drip is what you expect. If you're getting a lot more than that, unless the eye is very firm, you're going to get hypotony. This little well that the Paul glaucoma implant has is helpful in determining that you can see the aqueous coming up it. But if you just put a tube in and never look, then you never know if you're getting too much or too little until you measure the pressure the next day. Whereas with this technique, you can tell, and you can adjust it. You can ligate it if it's not enough. You know, if there's too much flow, you can ligate it, and if there's not enough flow, you can withdraw it a bit. Here, there's one where there's far too much flow, so then I would ligate it. We published the outcomes at 1 year of the Paul glaucoma implant in ophthalmology glaucoma. And just for comparison, these are going back to the Amid versus Barvelt study. At 1 year, Barvelts and the ABC combined analysis were getting pressures of around 13.7. At 1 year in our multi-center report, Barvelt's Paul glaucoma implant was producing very similar pressures on very little medication. So the only advantage of the Paul glaucoma implant really is the smaller tube. The smaller tube seems to give better predictability in the early postoperative period, which was serendipitous. It wasn't something we expected, but it should hopefully give better endothelial cell protection and less erosion. Current tube design is more than 25 years old. You know, the Amid and the Barvelt The only thing that the New World Medical have produced in the last few years is a ClearPath. The ClearPath's a knockoff of a Barvolt. The Barvolt's 25 years old, so why do you want to knock off a 25-year-old device? It doesn't make any sense. You know, the ADI, the Aravent implant, is a knockoff of the Barvolt. So, and it's much cheaper. So why would you use a ClearPath? It just doesn't. I just don't understand. Reducing tube diameter is an obvious fix that should produce benefits. And that's it. Thank you very much for your attention. There are more videos at these websites.
Well, so that's wonderful. Keith, do you want to unshare? We are running a little late, and I know that Prof. Keith Barton needs to go back to clinic. He's still running his morning clinic. So shall we, are there any burning questions for him before we let him go? Okay, I think actually, Keith, you've made things very, very clear. So that's wonderful. And see you very, very shortly. Please feel free to excuse yourself and go and see to your patients.
Thanks very much, Chris, and thank you to the panel.
Thank you. So now, are there any questions for the other three speakers? Silence. Okay, so then I think then we should move on because we are already a few minutes late. So we are now moving on to half an hour of ROP treatment. So firstly, I think we are going to do the injections talk. And so I would like to invite Dr. Parajat Chandra to tell us about anti-VEGFs for ROP. Dr. Parajat, please.
Is my screen visible?
Yes, Parajat.
So thank you for this talk. I'd like to talking about anti-VEGF drugs in ROP. So I have no financial interest in these drugs. So this is typically how a case of aggressive ROP used to look like following laser a few years back. And if you had shown me this photograph a few years back, I've been very happy and would have complimented the person who did such a nice laser in the case of aggressive ROP, which led the disease to go away. But there are a lot of problems with this photograph if I look at it in 2023. So there's a problem of limited visual field, tubular vision, poor macular perfusion, and there's the risk of high myopia. So all these problems are there, especially when now much better treatment modalities are now available. So there's no doubt about it that anti-VEGF over the last few years has emerged as the first-line treatment of zone 1 ROP. There are several advantages like rapid ROP regression. There's retinal revascularization, which will enable better visual field, better foveal structure, and of course, there are lesser refractive changes. And if you look at it, it's a much faster procedure. It causes much less pain, and obviously a more stable baby during the procedure if you compare it with laser. So we published this large series of aggressive posterior ROP, and there's a review if you want to look forward to it. So the Rainbow study was a landmark trial which appeared a few years back. It was a study in 225 babies, which compared different doses of ranibizumab with laser and found a significant benefit in the 0.2 milligram group when compared to laser. So this further led to the European Union and the European Commission to approve ranibizumab for the treatment of ROP. And therefore, it emerged as the first and only licensed pharmacological treatment as an alternative laser in ROP. Very recently, a few days back only, Eylea or aflibercept has also been approved as the first pharmacological treatment for ROP, which has been approved by the FDA. So this was on the basis of the Firefly and the Butterfly studies, which are ongoing. And a quick look at the Firefly studies, which was a randomized clinical trial published last year, shows that they compared 1/4 the dose of aflibercept with laser in a 2:1 randomized clinical trial over 24 weeks and across 27 countries, and they found comparable treatment benefit of aflibercept as compared to laser. However, the non-inferiority could not be established statistically. So what are the current usage scenarios when you use anti-VEGFs nowadays? So what I'm trying to show you here is two photographs of the right and left eye of a child coming with aggressive posterior ROP. And if you see here, the pupil is not dilating, and a closer look will reveal that it's got a lot of neovascularization at the pupillary area, which is preventing this pupil from dilating. So it's very difficult in this scenario to do laser or surgery or any other procedure in these eyes. However, if you give an intravitreal anti-VEGF injection, you just see in 3 days, magically, all of this neovascularization disappears, and the pupil dilates very well. So now you can go ahead and do laser or surgery or whatever treatment you want, and obviously the response to anti-VEGF will be much dramatic in this kind of eyes with aggressive ROP, which will also lead to superior disease regression. This is typically how a case of zone 1 ROP would look like, or aggressive ROP. And if you get a newcomer to go ahead and decide where to laser this, it's a problem. There's just a bunch of loops which you see. The demarcation is not very clear. It's not very clear where the stage is. It is also not very clear where the vascularized and the avascularized retina are, unless you decide to do an angiography. So how much to laser? And where is the macula? Is it vascularized, not vascularized? Very difficult to comment on all these. And if you use anti-VEGF in this case, obviously we know that the response will be much better. And it takes care of all these doubts and dilemmas which were there when you had to decide to laser. And obviously you really can't go ahead and laser till the posterior pole here, as a lot of visual field will be lost. So let's see how anti-VEGF works in these cases. So we published a last series of cases of our clinical profile and management. This paper published last year. If you want to have a look, you can go ahead and have it. So this is typically a case of zone 1 posterior ROP, which basically means it's even the fovea is not vascularized in these cases, and this is a very small area is there, which are marked with the white line. So what happens if you inject anti-VEGF in this eyes? If you see, this is what it looks like at 6 weeks post-injection. What you can appreciate here is that the retina has really grown forth, the macula is also vascularized, and now the child will have much better visual field. So this was never possible with laser alone. If you decide to laser this eye in the above two photographs, how much laser will you do? And even if you decide to laser, what will the field which will be less? And obviously the macula is not also vascularized. So the advantage which you get with anti-VEGF in these eyes is absolutely dramatic. And this is never possible with laser before. Let me show you another case scenario. So, this case is there, and we injected anti-VEGF in the eyes. What I'm trying to show you here is again the case of zone 1 posterior ROP. And what you see here is there's a tractional detachment occurring at the posterior pole. You can see hardly any vascularization is there. There is some preretinal hemorrhages at the posterior pole, but no retina is really seen. So what will you do in these cases? So you inject it in these cases, and see at 6 weeks, you see the retina has vascularized, and you can see the disc, the neovascularization has melted away, and you see that the tractional detachment is also gone. And you can see the white tissue which the arrow is pointing to, that is the posterior vitreous detachment has happened and has removed the traction altogether. So surgery was not required, and obviously the outcome is very good in these eyes. This is something which I really like to show. So this is a common scenario which we see in India. The child is already lasered in many places where injection facility is not available or not affordable, and they come to us like this. You can see here that's a case of aggressive ROP, which is already being lasered and continues to progress and go into stage 4. And you can appreciate the large amount of neovascularization which is there. So now this is a very bad scenario. If you go in for surgery alone, then you cannot stop it, and maybe the disease will continue to progress despite surgery. There's a high chance of intraoperative bleeding, high chance of postoperative bleeding, and the response can broadly be unpredictable. So this is what happens if you combine an anti-VEGF with surgery, and you see the response is very dramatic. This kind of outcome you could never expect with surgery alone, and the kind of clean picture which you get is absolutely outstanding. So we recommend that you combine anti-VEGF with surgery. So this is basically done at the end of the procedure under air. You inject half dose of anti-VEGF under air, intraoperatively only. And this is the kind of response you can get. Many people like to use it preoperatively, but again, that's a very selective case scenario. And it's a disease which is rapidly progressing. There's a problem of crunch which can happen, and it can close the funnel. So you really don't want to wait that long. And if you combine both in a similar procedure, it works very well. So we published this large series of cases. And if you want to have a look, please go ahead and read these cases out. We also like to use it in some cases of threshold ROP in cases where the response can be a little unpredictable. So you see in this case, we used laser with anti-VEGF. Anti-VEGF was injected the next day after laser. And you see, it just melts away. This is just a 1 week post laser plus injection picture. And you can see it just melts away. So sometimes if you have cases like this, and you just decide to laser, we are well aware that disease can continue to progress into stage 4 ROP, as laser needs time to act, whereas anti-VEGF works very fast. And if you combine both of these procedures together, in selected cases of zone 2 posterior ROP especially, it can work very well. So maybe if you get a case like this, you can give it a try of combining both these treatments, and the outcome can be much more predictable. And that is what we want eventually. It doesn't really mean that anti-VEGF is a magic drug and it will work in all cases of traction and all cases of places where the traction is progressing. So this is typically a case which was referred to us. It was already lasered. It was progressing into stage 4 ROP. You see here the neovascularization is not so much, but you see the fibrotic component and the traction is much more. So we advise this case for surgery. And however, the referring surgeon decided to inject in this case. And what happened was, this is what it came back to us after it came back to us 1 week later. So what I'm trying to show here is that we should not lose the valuable early surgical advantage when we have it. So the case photo in the left is a very good case for surgery right now, and not a case for injection. Also not a case for combination treatment, because we are well aware that if you inject a case of anti-VEGF, there's something called the crunch phenomena, where it can continue to progress despite your procedure. So wherever surgery works, anti-VEGF might not be the right treatment, and surgery might be a better treatment. So it's not a panacea for all these cases. So there are a lot of drugs in the market: bevacizumab, ranibizumab, aflibercept now also. So which drug should we be using? So in our experience, all of them work very well. All of them have a dramatic response on the disease process and can really do superior disease regression. So which drug to use? Obviously, all of them are there. So bevacizumab is not approved, and we still like to use it in some cases. Ranibizumab, and obviously bevacizumab, a lot of literature also there. Ranibizumab is approved in the European Union. IOS, as I showed you, is now approved by the FDA. What dose to use? Mostly people are using half dose, adult dose, although there are a lot of drugs, a lot of literature which is there, which is ultra low doses where people are using 1/4 dose, 1/10 dose, and they're also reporting very good response with those doses as well. But usually universally people are using half dose, half the adult dose. And obviously, as you saw in the Firefly study, they're using 1/4 the dose of aflibercept. Even in the Rainbow, customized doses of ranibizumab were used in 2 different doses. How many injections? Usually the 1 injection is enough, especially in cases of bevacizumab or Eylea, where which are more longer acting drugs, and recurrences are more common in ranibizumab. But even if it recurs and recurs very forcefully, then possibly you might try an injection, which I'll just come to in a while. How to inject? We like to inject in the operation theater. It provides a sterile environment. It provides a more controlled scenario where you can put the child in a situation where it's easier to inject under an OT microscope with providing proper magnification. A lot of people like to inject in NICU settings, in sterile settings, and I think that should not be recommended. And the correct way to do it, as we like to do it, is in the operation theater. And obviously, we like to inject bilaterally in the same sitting. Obviously, this has to be treated like 2 separate procedures, which means basically you have to clean drape again. You have to change the gloves. You have to change all the equipment so that it can be done in the proper setting. And obviously, 2 separate injections have to be used, and drug batches, if different, again, it's much preferable. This is another big problem which happens. A lot of these cases are coming for children which are injected in an ICU setting without proper magnification, without proper sterility. Of course, it's possible in the best of OT scenarios as well, but the likelihood is less when you have proper magnification, control over the baby, and a more sterile environment to deal with this. So what happens once you inject? So after a while, the retina, as I showed you, continues to grow. Sometimes after a while, it stops growing. And the ICROP3 has termed as the peripheral avascular retina, or the PAR. So if you have a large peripheral avascular retina and the disease does not recur, then there's a chance that a large peripheral avascular area is still remaining behind, and there's a chance of late reactivation, which has well been reported in literature after weeks and months and years. Therefore, if you have a large peripheral avascular retina which is remaining after 10 to 12 weeks, we suggest you go ahead and laser these areas. I think the biggest problem which we have right now is managing reactivation. So as we are well aware, the effect of drug finishes off in a few weeks, and then there's a high chance that the disease will come back. Aflibercept bevacizumab have a longer duration of action when compared to ranibizumab, and this last trial showed that there's a high rate of reactivation with ranibizumab. So what do you do? So you have to maintain a high index of suspicion that the disease is going to come back. And obviously 4 to 8 weeks is a critical time. Look for the plus coming back, look for the ridge coming back, look for flat neovascularization. And if it starts to come back, then you need to go ahead and treat these eyes. So we like to do them with laser, but I'll show you some special scenarios. So when should we go for a repeat injection? So as I'm showing you this eye is having a severe reactivation at 6 weeks. And you know, you need now fast a drug to act on this. If you do laser, it might not work as fast as an injection might do, because a lot of neovascularization coming back, a lot of hemorrhages happening in these eyes, a lot of plus disease coming back. This is another scenario where you have lasered as well as injected, but now you see again the disease trying to come back. So obviously there is no more laser you can do. Posterior barrage laser is not an option in a very small vascularized retina. So in this case, possibly another injection would be a good idea to do it, and don't let it rise. And if the TRD has happened, then possibly you might have to combine with surgery also. If it reactivates after the second injection, then possibly you would want to switch the drug to a more longer acting agent like bevacizumab, which we like to do in some selected cases. Another scenario of poor regrowth is there. So you see the retina has grown, but it's not grown significantly, and the significant peripheral avascular retina is left at 12 weeks. And possibly if you inject more, there's a chance that it might grow more. So you might consider another injection here. There's another case where again you see very poor regrowth has happened if you see at the arrows which are there, and it's again reactivating. So now one option is you can do laser, but why not inject again and let the retina grow further, and then possibly if it reactivates again, you might want to do it. And possibly you might also consider switching the agent here because a significant growth response was not seen in the eye. So I've showed you a lot of case scenarios, and I would just like to highlight here, this is the JSSK program, a very big program of the government of India, which provides free transport, diagnostics, treatment to pregnant ladies and children less than 1 year. So in hospital, we have to basically subscribe to this program. It allows us to provide free injections to a large number of these babies. So last year, we did around 600 injections, which were given to these babies last year itself. And all these were supported by the huge JSSK program of the government of India, where we are able to provide this quality of care free of cost to these babies. So thank you so much for this opportunity.
Thank you, Dr. Parfet, for this nice presentation. Now I would like to introduce Mr. Chin Woong, who is a pioneer in endoscopic vitreoretinal surgery for ROP. He works in Great Ormond, Morpheus, and OCL.
Thank you very much for the kind invitation, Professor Bhagat, Christopher Liu, and the panel. I'd like to talk about advances in surgical management of ROP centered on our UK experience and my experiences from running the UK National Centre at Great Ormond Street Hospital. Here are my relevant financial disclosures. So as we have heard in the last talk, ROP can present at different stages, and about 5% of cases can fail anti-VEGF laser therapy and progressive retinal detachment. So stage 4A is MAC on, 4B is MAC off, and stage 5 is total. So I'd like to, I think our experience in the UK for us has been very informative, and we, in the 10 years preceding my involvement, work was done primarily at Oxford University, whereby they achieve an anatomic success rate of 55%. So in the past, since 2015, the service in the UK and the provision has evolved. And the question is, how will we be able to get from 55% to 88%? So one of the things that has happened is that we're doing these surgeries earlier. So the time to surgery has reduced from 48 to 45 weeks. And even though it's a relatively rare disease, ROP is in its fourth epidemic now, and it is, as we've heard from the last speaker, it's one of the most important causes of childhood blindness, preventable childhood blindness. So in the UK, we are now receiving referrals earlier. How did we manage to achieve that? the screeners and the ROP screeners in the local units and treaters are really the key people, because the best route to an optimum outcome is earlier referral. So we've started engaging people on the ground about potential referrals about what early changes can look like. So the eye on the left here is normal, and the eye on the right, the blood is a giveaway. But if you pay attention to the first order blood vessels coming out of the optic nerve, some of those early changes, once you get used to looking for them, can be identified quite early. So dragging is when the temporal vessels are drawn towards the horizontal midline, so there's flattening of that angle. And here you can see traction retinal detachment in the far periphery. So you don't have to necessarily examine the far periphery in these babies that are moving in the neonatal intensive care unit. You can just look at the posterior pole and look at the angle of the vessels. And when dragging is more severe, the nasal vessels get pulled across the vertical midline as well, as shown towards the temporal side. So what about this case? Here's another example of a case where, is there dragging? Well, there is dragging. It is relatively mild, and it takes, some practice to identify it. But there is some flattening in the first order vessel, and you can see fibrosis there. And this is a case showing asymmetry between the two eyes. The right eye has very subtle flattening of the first order vessel there. And it's only through scleral indentation that early fibrosis and traction retinal detachment is identifiable. However, if you look at the other eye, the dragging is more pronounced. There's greater flattening. The flattening of the first order vessel extends out towards the second order vessel, and you don't need to indent to see the TRD. We are also able to do surgery earlier now in the UK, and the reason we've been able to achieve that is that the referral and the surgical treatment is now coordinated in the UK. We are fortunate to have to be able to arrive at this point where there is buy-in from pediatric ophthalmologists and vitreoretinal surgeons to agree that there should be one surgical treatment center. So we have access to better access to beds for children for transfers and surgery earlier surgical access. So why do we continue to get ROP retinal attachments? We've heard a lot about injections and the timing with the last speaker, but one of the foundations of of treatment remains laser. And laser treatment in ROP is difficult, even with experienced treaters. And this here's an example of a case for bilateral stage 4A detachment. And at the time of surgery, the area circled in red is where there were skip lesions in the far peripheral retina where laser was inadequate. And that's easy for anybody to do. So one of the other changes is our surgical technique in the UK has evolved. So in the previous study, vitrectomy would have been combined with lancectomy or buccal. Over the past 7 years, we've been able to move away from that towards vitrectomy alone, and they've all been lens sparing. And I'll show you why we've been able to achieve that. So one of the key challenges of ROP surgery is lens preservation. There's an impact on outcomes. It increases glaucoma risk by up to 9 times, and there's implications on amblyopia and visual rehabilitation. Lens preservation is challenging because with some of these cases, the traction retinal attachment is very anterior. It comes close to the pars plicata. We can't place the sclerotomy safely, and we end up risking iatrogenic retinal break formation, which during trocar insertion, which typically leads to total detachment failure and phthisis. This is very different from adult vitreoretinal surgery. Secondly, there are multiple vectors of traction with these cases, some of which, again, come up very anteriorly, and to be able to visualize and adequately dissect that, sometimes the lens needs to be sacrificed. So here's an example of a child who has a 4B detachment in the left eye. We know that the detachment is highly elevated because these are RETCAM images taken from the posterior segment, and the picture on the right is focused at the highest point of the detachment, and the posterior pole is completely out of focus, so it's highly elevated. So the management historically had been encircling buccal, but that was suboptimal because it only addressed one or two of the vectors of traction. Vitrectomy is the treatment of choice, but we've heard that safe entry into the eye, something we take for granted in adults, is not straightforward in these children. So we end up having to sacrifice the lens to enable safe surgery in many cases. So here's an example of the standard vitreoretinal approach with a non-contact wide-angle viewing system, where there's the biome, ReSight, and any other system that you'd like to use. So it's a top-down view. The endoscope provides an alternative view. It's from where the camera sits inside the eye and can directly visualize internal structures, such as the pars plicata and behind the lens directly. I'll show you some videos in a moment. So here is that case, the 4B detachment eye. So here's the endoscope view, which is unique. There's clear lens at the top. There's traction retinal detachment coming up towards the lens. We're looking at a 23 gauge MVR blade being inserted through the pars plicata. With the standard trocar insertion technique, we can't do this with confidence. It's essentially a blind insertion. With the endoscope visualization, we can directly guide the passage of this MVR blade in that tight space between lens and retina and preserve both tissues, and therefore avoid a lower risk, lensectomy procedure that's required in a conventional setting. Here's an example of another child that have a left eye inoperable end-stage, stage 5 disease. So only eye patient, 4B detachment in the right eye, significant traction with macular rotation, heterotopia. And here's the endoscope view once again. Okay, it's a unique perspective. There's clear lens, normal lens at the top. We've got the MVR blade being inserted through the pars plicata, and the tip is pushing against some white tissues, fibrosis, and possibly retina. So if one were to proceed with that, there's risk of iatrogenic break. So with the endoscope view, we're able to reposition the blade reliably and enter the eye safely, again preserving both tissues. So in the UK, we've now evolved the technique with simultaneous visualization using both microscope and endoscope views during surgery. So here's an example of the difference between the two views. So here's a 4A detachment MAC-on. On the bottom left is the standard microscope view that you'll all be familiar with. And the visualization of the vectors of traction is very different from the endoscope view on the top right, whereby you can see all the different vectors of traction coming anteriorly, as opposed to the top with the microscope view. Here's another child, a bilateral stage 4A. So the macula is spared, and you would hope for a relatively good visual outcome. The challenge here is that with the microscope view, the traction is very peripheral. You can barely see it. And the only way to reliably relieve all the traction is either do a buccal or remove the lens. With the endoscope view, we can see there's a curtain of traction covering the pars plicata right behind the lens. We can directly visualize that, accurately dissect through that, and we can now see that the traction has been removed, the lens is still clear, the pars plicata is visible, and the underlying traction retinal detachment is safe, and that an iatrogenic break has not occurred. So here's our 6-year data, single center, to show you what kind of results we can potentially get. We use a 2-step trocar insertion technique, temporal approach for maximum surgical dissection, and only air tamponade. We've had 113 eyes and 30 months mean follow-up, so almost 3 years of follow-up. So majority was stage 4A, so we're getting these cases relatively early, so they're macular sparing. Majority have had laser. There is a trend more recently towards more anti-VEGF injections. So overall, final reattachment rate 88%. That's comparable to some other published retrospective series. But the key slide is this: primary lensectomy was required in none of the cases in this consecutive national series. What about visual outcomes? Well, we were able to achieve perception of light or better
Thank you very much, Chen. So, I mean, I think we've got 2 experts in ROP, and I'd like you to talk to one another and see if there is any differences in opinion, or are you now off accord?
Yeah. Good evening, Dr. Wong. So I think it's really interesting to hear your lecture, and I think it's an amazing series of endoscopic vitrectomies which you've done. And I think very few people are doing this, and the results that no lensectomy was needed, again, I think is a very encouraging outcome which you see in these cases, especially because through the normal microscope, it becomes very difficult to actually relieve that kind of traction which is there. So I think it's really wonderful to see a series of cases. So I would just like to just put in a small point here. So when do you like to do these cases? Let's say a child comes at 50 weeks post-menstrual age. He's got like a falciform fold of the retina. And, mostly these are like cases of ROP sequelae, which many people don't want to touch. So which cases do you feel are very good for endoscopic maneuvers?
Thank you, Professor Chandra. I too enjoyed your talk, and you made some really important points. I think we find that generally the disease can progress asymmetrically, but usually if there's traction retinal detachment in one eye, the other eye tends to follow suit. So I would, our general approach is as early as possible, and I think it may be that for example, in India. In some of the countries, you may be seeing a different type of patient. You have larger, bigger babies, bigger, older babies, and you showed a very nice case of very vascular patient with significant traction, and we don't see as much of that. In the UK, we tend to see kind of very discrete kind of vascular phase, and then they enter a fibrotic phase. Hence, we almost never need to use anti-VEGFs. in the lead up to vitrectomy for traction retinal detachment. But to answer your question, we would do it as soon as we can, really. The only scenario whereby we would not do surgery if the other eye is completely completely secure and the disease is completely subsided. Then, if the other eye, one eye is 4B and the other eye is resolved, then, I think there's probably little role in doing surgery in that scenario.
And you basically like to do it just for the entry, or do you do some other procedure also using endoscopic?
So we usually use it as an adjunct during visualization, during vitrectomy surgery. So the microscope view is still the key part of it. That's what we need in all cases. And there are certain instances where we're looking at more anterior pathology, for example, where there is anterior zone 2, initial disease and traction is very anterior, then the endoscope becomes very useful. But for example, when there is posterior zone 2 or zone 1 traction, then the endoscope's role is very limited.
Yes, of course. Thank you.
Thank you.
So I think we get any other question which you have, Dr. Wong, on this thing.
So what is your preference now in terms of which anti-VEGF you would use?
Yeah, so basically we have been using ranibizumab for a long time now. Earlier we used to use bevacizumab. So because bevacizumab now no longer has those kind of approvals, which ranibizumab has from a lot of drug companies, we are using ranibizumab for a long time. But this recent development of aflibercept, I think, is very interesting. But obviously the cost is more. Aflibercept costs more than ranibizumab. And I think really the big change which is happening right now is the growth of biosimilars. So we have a lot of brands coming in the Indian market for biosimilars, which are basically ranibizumab, but the costing is much less. So it's something which needs to be looked into. There are not large-scale studies using biosimilars, but that is being readily, easily available in the market right now. And people have to choose whether they want to go in for a biosimilar or get the main drug. Second interesting development, I think, which is happening is with the availability of pre-filled syringes. So unfortunately, they are not becoming available for pediatric use, as many of people like to use half dose, 1/4 dose. If a pre-filled syringe comes, I think, although it is coming in a lot of the market and replacing the drugs, because it just takes away the whole process of making the drug using syringe and drawing it out from the vial and all. So again, I think pre-filled syringes also are coming in a big way. They're not coming for pediatric use, which again makes us look back to the same old process of filling the syringes the usual way.
Are you seeing? Thank you. Are you seeing an issue with follow-up following injections? You live in a big country, and are patients kind of coming back for their reviews? Are they presenting later with kind of complications because they haven't been monitored? Are you guys kind of doing laser before they return to their local cities or villages? Or what are you doing?
So we like to keep them in a tight follow-up every 2 weeks. And as we are well aware, it's going to come back in 4 to 8 weeks. It tends to come back and actually comes back like clockwork, especially because we're using ranibizumab, which has a higher recurrence rate. So we do hold on to them. And fortunately, patients, we counsel them in such a way that really they do hold on and they keep on coming because they're aware that the problem is not over. When giving the primary injection, we tell them, this is going to last for 4 to 8 weeks. Then either you need more injections or more laser after that to finish off the disease. So I think the parents are really very concerned, and the awareness is there once they reach a hospital that this is a problem which we need to fix. And so I think they continue to come for follow-up, and I think it's very nice that they continue to come for follow-up, and we're able to preserve these eyes for the treatment. Yeah, I think it really works very well. I think we need a longer acting agents so that this reactivation problem can go away and we're able to get away with one procedure. I think that is the future. I think that is the pharmacological treatment of ROP. That is the future. If you can just inject and forget it, I think that is the best way which we look forward to in the future with longer acting drugs. Thank you so much.
Great, thank you.
Gentlemen, thank you very much. I think that's a really good elucidation of ROP. So now we move on to our final hour or 45 minutes. And I'm going to hand over the microphone to Prof. Bhagat and also Dr. Basak. We're on to lamellar keratoplasty now.
Thank you, Christopher. So we will begin the session of lamellar keratoplasty, and I would like to introduce our first presentation. Dr. Rajesh Sinha, who will discuss anterior lamellar keratoplasty for corneal opacity.
Thanks a lot. I'll be discussing with you about automated anterior lamellar keratoplasty. A very specific topic. It started with the advent of the microkeratome and the artificial chamber and this console. And then it was used, and it is still being used for superficial corneal dystrophies, superficial opacities, scars, granular dystrophy, band-shaped keratopathies, Freudian degeneration, trachomatous keratopathy, and in these it works quite well. So on an artificial chamber and with the microkeratome, we run, and that's how we create the donor lenticule. And then in a host, again, we use the suction ring, and with a microkeratome head, we first look at the cornea with the anterior segment OCT, see how much depth is the disease, about 250, 300, whatever. Depending upon that, we can use the head, and that's how we debulk or reduce or remove the opacity completely or near completely, so that we can provide a similar thickness of donor lenticule and provide a good outcome. You can see the scar has been mostly removed and the visual axis area is clear. You can also combine it with a phacoemulsification in cases of, say, bad trachomatous keratopathy. In such a case, with the help of microkeratome, you can clear the visual axis quite significantly. And once you clear well, then you can see how well it looks now. And once you remove the opacity, you can, in order to improve visualization, then you can go ahead and complete the cataract surgery and place the intraocular lens under direct visualization, the very good visualization, and then replace this removed tissue with a donor lenticule of similar thickness. And that is how we perform the anterior lamellar keratoplasty in these cases. And with the automated keratoplasty, the interface is very good, and that's the advantage. The interface is very regular. We did a study long back at RP Center, and that was comparing automated keratoplasty versus manual keratoplasty, and we found out that it took less surgical time. There was early epithelialization. There was better contrast and glare acuities, and early visual rehabilitation was seen. And better visual outcome, better contrast, better glare acuity. You can see here that in case of lattice dystrophy, this was done when you see that the opacity is involving anterior stroma, mostly in lattice we do talc these days. Case of a multiple corneal foreign body which is involving superficially, you can cut the superficial corneal tissue. Scar, wherein you can reduce the density of the scar. A healed keratitis, again, you reduce. The idea is that you reduce the bulk, you reduce the density of the scar, so that the scar becomes faint or it goes away completely, and then you can place another lenticule created by the microkeratome. So that's how you get a very smooth interface, and the visual quantity and quality is much better. And with a manual lamellar keratoplasty, sometimes you get to see a debris, sometimes you can have irregularities, sometimes you can have interface haze, and that is there is the advantage of using the microkeratome in creating a smooth surface. This is a study which we published long back in the year 2012, automated keratoplasty in trachomatis keratopathy. Now, if the opacity is involving superficially up to 200 microns, in such a case, we can leave it sutureless. So this is a donor lenticule that is being fashioned on microkeratome. As you can see here, this is again a trachomatis keratopathy, a couple of nodules which are being manually removed. When there's a nodule, it's always better to remove it manually and do a manual keratectomy and then use a microkeratome. You can see how clear it has become. A little bit of cataract is there, so it's always better to remove the cataract, place the intraocular lens. And once you place the intraocular lens, you can inject air for some time in order to have a nice, well-formed chamber, and then put a donor lenticule of the same size and of similar thickness. And then you dry the edges. And once you dry the edges, you put fibrin glue at the edge and then place a bandage contact lens. So the fibrin glue actually keeps it for a few days. We keep an extended period of bandage contact lens we prefer using it for 3 weeks actually, where we can change after 10 days and we can put another bandage contact lens. So that is what we do in a sutureless anterior laminar keratoplasty. Conditions like a granular dystrophy, it works very well because most of the opacities are up to say 200 or 250 microns. So you can, even if it goes beyond 200, you can debride the epithelium and then cut 200, have a 200 micron tissue. And what we have noticed that in a 200 micron tissue, we don't require a suture, it stays well. And this, I guess the concept came when we had a free cap in LASE. And then that cap was when placed and put a bandage, when the bandage contact lens was placed, it remained there. So that was the basic idea of doing a salve. You can see this granular dystrophy, how nicely it's a sutureless keratoplasty, no opacity is there. It's almost clear. You can see 1 or 2 opacities here in the peripheral part, which doesn't carry much significance. So it works quite well. A case of a post-LASIK epithelial ingrowth wherein this patient was observed because the epithelial ingrowth was in the periphery and that resulted in flap melting. So in such a scenario, there are 2 options. Either you can amputate the flap, debride, remove the epithelium completely, and you can leave it like that. But if there is availability of corneal tissue and if the cornea surgeon is handling it, it's always better to replace the tissue of similar thickness and of similar size. And this similar thickness and size can be determined by anterior segment OCT. We can get to know that what was the flap thickness, and that is how we in this case, the epithelial ingrowth is being debrided and then mitomycin C will be used. And then donor lenticule is being positioned and of similar size and thickness. And you dry the edges. You dry the edges and then put fibrin glue at the edge, and then put a bandage contact lens, and it works quite well. Femtosecond assisted anterior laminar keratoplasty works very well, particularly if you go deeper, the irregularity in the interface is there. But in a case of a sutureless keratoplasty, when you are using up to 150, 200 microns, in such a case, what we get is that we get a very nice vertical edge. So edge-to-edge apposition and the risk of epithelial ingrowth is absolutely insignificant. The apposition is much better if you use a femtosecond laser. So this is how we do it. And we lift the flap, we remove it, and then we take the patient to the routine from the femtosecond laser. The patient has been shifted to the routine OR. As you can see, this is the superficial part is quite hazy. It is a case of a healed keratitis with some vascularization. That is why there's bleeding. So now this tissue is being removed, will be placed in position, and you can see the edge is quite vertical, and a little bit of irregularity was there because of the scars. So trying to smoothen it. We shouldn't use too much of burr, otherwise that will also cause scarring. So we have to be very judicious in its use in the interface on the stroma surface. And then we can place the lenticule, and there's very nice edge-to-edge apposition if you use femtosecond laser for dissection. So in conclusion, automated anterior laminar keratoplasty is quite safe. It provides good result because the interface is good, so the quantity and quality of vision is better in comparison to a manual anterior laminar keratoplasty. Thank you very much for your patient listening.
Thank you very much, Dr. Rajesh, for this nice presentation. Now I'm going to share my screen.
Our next speaker will be Dr. Bhagat Muhammad, and he will be speaking on DM perforation and management in DALC to complete, how to complete it.
So, is my screen clear for all?
Yes.
Okay. So we are going deeper in the field of lamellar keratoplasty. I'm going to discuss descemet membrane perforation in DALC and how to complete the surgery. We all know that DALC is a surgical procedure in which the anterior layers of the cornea are removed, leaving only descemet membrane and a very thin layer of the stroma, which is called the predescemetic layer or Duas layer. The ideal is to leave this layer intact. However, this is not the rule in most of the cases. You may have tears in this layer. The tears may be a pre-existing perforation, or it may happen during the course of the surgery. So dealing with the DALC with a pre-existing perforation, such as cases of post-hydrops scar. In these cases, we avoid the area of perforation during the section. Now we are injecting air in the stroma, not aiming to have a big bubble, but just to have the corneal whitening, which will guide us to the desired plan. After removing 1 or 2 layers of the stroma, I'm going to start dissection in the periphery, avoiding the central area. Leaving the central area to be the last area to be removed during the surgery. This is guided usually by the small micro bubbles in the stroma. So this can guide us to the predescemetic layer. We do a 360 degrees dissection. Once we reach the desired plan, we start peeling the central area. We know that there is a perforation in this central area, and we are expecting aqueous to egress. And once you have the perforation, you peel from the opposite side to avoid the perforation to become large. And here we can find that there is a very small perforation. You can inject air in the anterior chamber and safely put your graft. So this technique has been published since 3 years in the Cornea Journal. And the rationale of the peripheral dissection is to avoid the area of perforation and to ensure dissection on a formed globe, because if the globe is open, dissection will be difficult. And if dissection is difficult, you will not have an ideal graft-host junction. You peel the central area to reach a clear predescemetic plan to ensure removal of the scar and to provide a smooth interface in the central area. What about the intraoperative perforation? Perforation can occur in any step of the DALC surgery. It may occur during trephination, during introduction of the cannula, during air injection, during removal of the stroma, and even during suturing. So during trephination, this is a case in which I had an accidental full thickness trephination in 2 areas. So I had a very large, a significantly large perforation in the temporal and nasal area. Still, you can continue dark, just suture the area of perforation, start injection air in the stoma. You may be lucky and have a big bubble, but usually you will not have it because air will escape from the site of the perforation. Here we are stressing on the central area and leaving the part of the perforation to be the last part to dissect. I also use the micro bubbles in the stoma and introduce a blunt spatula. After reaching the predisseminatic layer, which is evident by the absence of the microbubbles, you can cut the sutured area and continue the section in the perforated area. And finally, you can safely put your graft and suture it. So to avoid perforation during trephination, you should read the manual of your trephine and know how many turns you need to reach the desired depth. You can use guarded trephines, however, it is more expensive than the traditional trephines. If you have area of thinning, such as in pellucid marginal degeneration, you should plan a large trephination to include the area of the thinning inside the trephined area. If you are not sure of the depth, just aim for superficial trephination and continue with a super plate. And if full thickness trephination happens, then suture the perforated quadrants and continue that. Perforation can occur during introduction of the air injection cannula, although I use the Fogla plant cannula, but here it is introduced in the center of the cornea, which is usually thin and weak. And you can find that there is some egress of aqueous indicating that the cannula has perforated the Smith membrane. You use the same technique we used in eyes with post-hydroxy scar, doing a peripheral dissection and then peeling the central area, which harboring a perforation. And we are expecting also a perforation in this area. Now the perforation occurred and we are removing the stoma. We can just unfold the edges of perforation and finally put the graft after removing the Smith membrane. So to avoid perforation during cannula introduction, you should use a blunt air injection cannula and avoid thin and scarred part of the stoma. The cannula should be introduced slowly in the mid-stoma, and if perforation occurs, dissect the stoma around the area of perforation till reaching the desired length, followed by gentle peeling of the stoma overlying the tail. Now, I'm going to present the bursting of the bubble during the air injection. So this is the case of post-microbial keratitis scar. And I am now doing air injection. You will find that the big bubble will form, and accidentally I felt the popping of the bursting of the big bubble, and the air is filling the anterior chamber now. And sometimes you can see the area of the perforation through the cornea. I'm pointing to the area of perforation. You can do the same as we did before, doing a peripheral dissection around the area of perforation, and finally doing peeling of the stoma over the perforated area. So to avoid this, air should be injected slowly. Once the bubble reaches the trephination groove, stop injection. If you find resistance during the bubble formation, do not increase the force of injection. If the bubble is formed, an incomplete bubble formed, and you find resistance, do not increase the force of injection. Just stop injection and continue by manual dissection. Perforation can occur also during the stomal removal. Here I had an incomplete bubble, so I continued surgery by doing some manual dissection, and I felt the perforation in the upper quadrant. This quadrant, I felt there is a perforation. So I left this quadrant to be the last to be removed. And now I am trying to remove the quadrant and doing some lamellar dissection to leave a stromal patch sealing the perforation. This is a peripheral perforation, so still you can leave some part of the stroma to seal the perforation. So if perforation occurred during the stromal removal, to avoid this, you should dissect the stroma from the pre-descemetic layer before cutting with scissors. And if perforation occurs, continue the section sparing the stroma around the tear. And if the perforation is peripheral, you can leave a stromal patch to seal the perforation. Also, during manual dissection, this is a case of a 6-month infant with a corneal dermoid. I'm performing DALC with a very large trepanation, about 10 millimeter. No bubble is formed, so I'm going to continue dissection manually. And I'm trying to find the proper plane, but unfortunately here I had a perforation, a very small perforation. So I continued the section away from the perforation, and now I'm having another perforation. So a 6-month infant and with a 10 millimeter corneal graft, so no place for conversion to penetrating keratoplasty. Luckily, I found the desired plan, so I decided just to bare the central area and to leave the stroma sealing the perforation, because it will be difficult if I bare the perforation. It will be difficult in the area management strategies in such an infant. So finally, perforation can occur during suturing, especially if during the second and the third and the fourth cardinal suture, because this usually there is a pressure on the globe. And here the perforation happened. But this is simple in the last step. You can just continue suturing and inject air in the anterior chamber. So the general rules for perforation is to complete the section away from the area of perforation. Try to seal the stroma, the perforation with the stroma during dissection to avoid hypotony. If aqueous continue to leak, try repeated intracameral air injection. Avoid viscoelastic. Peeling should be gradually and equally from all directions of perforation. Try to preserve all descemet membrane and avoid losing any tissue. So these are pictures of a long-term follow-up after large perforation. This is a case with large perforation, and this is an interesting case with a burst type 2 bubble after preparing the graft. So I had to put the graft. Here the descemet membrane is crumpled to one side, and all this area is devoid of descemet membrane, although the cornea is clear and specular microscopy show that there are endothelial cells in this area with an endothelial count of 1,800. Here is another case of DALC with large perforation. So this is complicated with oryzocavalia, unfortunately, due to bad management of the area in the post-operative period. Another perforation with a limbus to limbus perforation and the central area devoid of descemet, although the cornea is clear. So my take-home message is descemet membrane perforation is a challenging situation that should be managed properly. All perforation can be fixed intraoperatively. Repeated air injection may be needed in the post-operative period to manage double AC. Proper air management strategies should be applied to guard against pupillary block and Ehlers-Danlos syndrome, and try not to convert to penetrating keratoplast. Thank you.
Thank you, Dr. Bhagat. So this is wonderful videos and your brave way of managing all the cases in all levels of perforation and very nice videos. So as we are short in time, so I'll be calling upon my friend Dr. Rajesh. He will be speaking on innovations in DMEC. Rajesh is a wonderful.
Thank you. My slides are visible?
Yes, yes.
Okay. Yeah, at the outset, I would like to thank both AIOS and the Royal College of Ophthalmologists for inviting me to be part of this session. I'll be talking about some of the innovations in DMEC, which have made the surgery easier to perform. I have no financial interest to disclose. DMEC is currently the preferred technique of endothelial keratoplasty among corneal surgeons worldwide. And if we look at data from the Eye Bank Association of America, we will see that every year the number of DMEC surgeries being performed is progressively increasing. Is minimally invasive, results in a faster visual recovery, minimal refractive shift, and the reduced risk of rejection makes it a procedure of choice. However, for people who have completed fellowships, they are transitioning to DMEC. The most common barriers are basically either related to incorrect orientation of the Descemet's membrane donor or the anxiety related to donor preparation, especially in part of the world where the eye banks don't give you a pre-prepared tissue. So at least in our part of the world, surgeons have to prepare their own donor Descemet stripping. It's fairly reproducible using donor between the age group 50 to 70 years, which is ideal. You do put a F or an S stamp for proper orientation and stain the donor with trypan blue for 1 to 2 minutes for proper visibility. Loss of tissue leads to cancellation of surgery, additional financial burden, and it steepens the learning curve. We described this interesting device which has retroillumination, which was published last year in the IGO. So here, just like what you see, like anterior capsule in your capsulorhexis, here as the Descemet is being peeled off, the visibility is highly improved against the retroillumination provided with this endothelial punch, which is again in production by Network Medicals, and it should be available in the market soon. And you can see the amount of change in contrast between the conventional peeling and peeling using this device with the retroillumination. The other technique that I recently started using is a technique described by Peter Schurschman called the liquid bubble technique. However, instead of making a track, we use a needle, a 27 gauge needle, to induce a type 2 bubble by injecting fluid. And once you induce the bubble, you can then further enlarge it by injecting trypan blue, which makes the separation of the Descemet's membrane fairly, easy to perform with minimal manipulation. It stains the stromal side of the DM, and putting an air bubble within the fold of the DM, you can stain the stromal side of the DM without having to make a stromal window. And then you can punch out 8 millimeter or a 7.5 millimeter of the donor DM, and that's ready for injection. In insertion and unfolding, we traditionally use the fluid-based injection where the DM is flushed into the anterior chamber. However, if there is upthrust or the anterior chamber has limited space, sometimes there is a tendency for the donor DM to try and rush out of the main wound if it is leaky or it goes towards the side port. So makes it slightly difficult. So, and also when you flush the tissue rapidly into the anterior chamber, it tends to lose its configuration and achieves one of these various configuration, which then you have to manipulate to get the donor scroll to open up. The most ideal of them being the double scroll configuration. So we devised a technique which was again published in Cornea last year, where we try to achieve a double scroll configuration. So here, the donor scroll is aspirated into the wider part of the goiter injector, and then you bring it to the narrow part. And as you agitate the fluid back and forth, when the scroll moves from the narrow part to the wider part, it opens up. And then when it re-scrolls, it can go into a double scroll configuration. And we found that this is almost 85% when you use it between the donor group 60 to 75 years. Younger donor, it's a bit challenging because the tendency for the scroll to go into a tight scroll is pretty high, and it doesn't open up even when you're trying to agitate the fluid. The second thing is the use of AC maintainer to try and create a unidirectional flow. So in this, the AC maintainer is connected and it's switched on, and then you introduce the DMEC injector tip into the anterior chamber, after which you rotate the tip to ensure that the DM scroll within the injector, the open end is facing upwards. Once this is achieved, and then you can ask your nurse to stop the flow in the AC maintainer so that there is no more fluid coming into the anterior chamber, and instruct her to disconnect the AC maintainer from the IV tubing. So now the AC maintainer acts as the egress point of fluid from the anterior chamber outwards. And now when you inject the DM scroll, there is no excessive buildup of fluid in the anterior chamber, and the chamber immediately shallows once your donor scroll is inside the eye, and the orientation of the scroll is also maintained. So you will see in this video that now we are injecting the scroll in the double scroll orientation, and it's gone into the anterior chamber. There is no tendency for the scroll to rush out because the pressure in the anterior chamber is low. The chamber is shallow, so the double scroll configuration is maintained. You secure the wound, and now you can see that we slightly deepen the chamber, and it's very easy to open up the double scroll. The average duration to unfolding was about 250 seconds, and in 75% of the eyes achieved 20/20 or better. And we had, the cell loss was lower than the traditional, being only about 16.7% at 6 months. And this possibly could be attributed to the minimal manipulation for donor unfolding. So you can see here that's an unedited video where we can see that the unfolding has been fairly simple, and you don't really need to manipulate the donor significantly. And once it's unfolded, you can put an air bubble, and that's the end of it. The second thing that we did was we often tend to introduce a small air bubble, whether it is to stain the donor DM using the air bubble within the fold, or to introduce a small air bubble within the tight scroll, or once the donor is unfolded, trying to put a small air bubble below the scroll. So these are quite challenging, especially if you use a syringe and a 30-gauge cannula. So we got the backflush cannula from the retinal surgeons, attached a 30-gauge cannula to it. Now we press on the silicone tubing, you get a very small air bubble that comes out from the tip. So this is much better than trying to push a plunger, wherein with a 30-gauge cannula, the air can get compressed, and you can get an uncontrolled, leakage of air from the tip. You can see how gently the air bubble can be introduced within the fold of scroll without displacing the folds. And then we can dry the surface, and you can use a Sinskey hook and marking ink, and you can just create your F or an S stamp. So this is quite useful, and in a very controlled manner. So we tried using a 1 ml syringe before, but then again, it works sometimes. Sometimes you get more air than what you wanted. But here it's fairly simple to use the backflush cannula. Again, you can see here there is an unfolded DM. There is a peripheral fold. You can go with the backflush cannula and just put in a small air bubble in the center without the fear of the donor DM getting displaced. And here we'll be using the air bubble to unfold that peripheral folded part of the donor DM. So you can just use the air bubble to manipulate. And the air bubble secures your DM, preventing it from getting displaced on either side. And then you can complete the DMEC therapy. For surgical training, this is again something that we described back in 2017, where on an artificial chamber, we put a latex diaphragm that's basically a piece of glove that is placed in between the donor tissue and the base of the artificial chamber. And by moving the latex diaphragm up or down through the tubing that's with the artificial chamber, you can shallow or deepen the chamber. And virtually, you can practice all the steps of DMEC. So this is fairly useful for teaching and training of the DMEC surgery. So you can see that in the wet lab, that's a 7 millimeter donor that has been stained, and it's introduced into the anterior chamber. And once it is introduced, you can secure the wound, and then the rest of the steps, like whatever you do in the patient's eye, the simulation is pretty good, and you can tap. You can either tap on the periphery or tap proximal to the fold, and by using a no-touch technique, you can get the graft to unfold. You can even move the graft to center it. by peripheral tapping, and then you can practice injecting the air bubble below the donor to ensure that you don't inject air above the donor graft. When you place in the cannula should turn blue when the air bubble is introduced. You can even deepen the chamber and you can practice how to flip over the graft. You can see that often we have eyes where the donor is in the upside down position. So this step can also be practiced, how to flip over a donor graft. So basically, in this short presentation, we have shown how these various innovations that I have introduced into my own technique of performing DMEK over the past 14 years, and which are trying to make it simplified. So DMEK now, at least in my practice, stands for definitely most easy keratoplasty. Thank you. Thank you for a patient hearing.
Thank you very much for your lovely presentation. Always very pleasure to listen you and learn a lot of things from you. So now I'll be sharing my screen. What is that? You can take screen.
While Dr. Samar Basak is getting his slides ready, let me just introduce him. He is a prolific corneal surgeon and a great teacher. He has done a huge number of DMEK surgeries, and he has been teaching and training all across India at various centers. And it would be very interesting to hear about his experience.
I have to go with my other laptop. Something is happening. It is not allowing that. System preference. It is.
While he is getting ready, just a few points on Dr. Goveda's excellent presentation. Okay, I think he has managed to.
Can you? Am I visible now?
Yes, you're visible.
So I'll be. Thank you very much for AIOC and Royal College for giving this opportunity. I'm sharing my experience of 1,000+ DMEK, and I'll be talking a little bit of some thoughts. So I do not have any financial interest. What's happening? It is not moving. So I always think that when I perform a DMEK surgery, normally I perform about 6 to 8 DMEK procedure in a week. Sometimes it is the second eye of Fuchs patient after treating their first eye about 4 to 6 weeks back. So this kind of faster sequential bilateral surgery is only possible because of DMEK provides quick unaided visual recovery. So when I look back, I started long time back, probably at the same time with Rajesh, but I failed to continue it because of a lot of failure in my beginning years in 2009 to 2016, and several attempts every year and several failures. And then I went back to DSEC for next 5 years. Till 2015-16, I was listening to Rajesh and other junior colleagues that what are the problems with me, and I practiced a lot of things in wet lab and Then the Beltzman paper came on S stamps, and a lot of things are easy. Actually, this S, F, or P, these marks are very important for Indian eyes, where the eyes are dark brown or dark colored eyes, or it is very difficult to see the orientation. And it is, I say that it is stromal site, it is severe, it is smooth surgery, and always it is a successful surgery. So there are two hurdles I have that Rajesh has shown all the tips of donor preparation. Donor preparation, I know that in Western world, it is by the eye banks, they prepared the tissue and they say that they are privileged and maybe spoiled, the surgeons. But they get all ready-made demacrol that is required for easygoing and for quick. You know that probably this year in US, the DMAC will surpass the DSEC in United States, because last year it is only a few hundred difference. Donor damage, as Rajesh said, it may be up to 20%, but usually with learning it reduced. And this is my that typical technique. I usually do most of my cases with this simple technique. It is usually 9.5. Then I make a stromal punch of 3 millimeter. And sometimes I use air also. Rajesh has shown the air, and you can use the tissue in both the ways. And then you make the stamp and you punch the tissue with the desired diameter. So it may be 8 millimeter, 7.5 millimeter, whatever size. So that unfolding is the second hurdle, and Rajesh has shown that beautiful ways of learning it. There are very YouTube videos are there, but anterior chamber fluid dynamics are very important. A bit of physics is important, and also as any asymmetrical mark, all are important. The anterior chamber depth, configuration of the iris, IOL position, whether in the bag or in the sulcus, or whether it is scleral fixated IOL, all depends. I try to look at the donor skull behavior before taking the thing in my injector system. Typically, I use this injector from IOL Curtis, and I try to see the donor, that you see the different types of scroll when you put the donor graft in a petri dish, and you see that the typical scroll is always classical double scroll, but we do not get always. But Rajesh has beautifully demonstrated that we can agitate the tissue and we can have those kind of configuration. And that unfolding, so when you go all the way with your procedures day by day, in typical scenario, you can do the same, redo the same procedure, and you just pin one side of the periphery and deepen the chamber, and with one hand or two hand techniques or little tapping on the dome of the cornea, you can unfold the whole tissue and gradually you try to center it. So little bit of fluid injection and fluid egression is important. When you are totally fine with the centering, you go right up to the center and give air bubble. Our published result in 600 eyes about 3 years back, the indication was like, we see a lot of cases in our part of the country, our APCD is around 36%, but whereas the other part, it is around 15%. But when I see this 1,000 result, the ratio has not changed much. I see a lot of HSB endothelial keratitis-induced edema, and also a lot of eye syndrome. And donor tissue typically between 37 to 90. I use a lot of tissue above the age of 80 years. But Again, the cell count in our part of the country is also higher than the rest of the country. So this is the preoperative presenting visual acuity. You see that we see a lot of bad cases when they present to us, but within 5 years, this vision is maintained around 20/30 at 60 months, that is 5 years follow-up. So when we see the graph of this, that 45% of our patients actually achieve 20/25 vision. It is unlike other people, they actually do more with Western world literature, they do more with FECD, about 70 to 80%. They are this 20/25 or better vision is about 80%, whereas my series, it is around 45%. Again, when I look my data, when 100 eyes, the 3-month cell loss was 26%. Then when I checked about 1 year ECL up, it is about 34%. But when compared the two results between FECD eyes and PBK eyes or other causes, the difference is usually 33 versus 41%. This is the 4.5 years follow-up. This is around 2 years follow-up. But you see the endothelial cell density over 5 years. We start with 2,800 cells, then gradually downs, and it is 1,400 at 5 years, and cell loss after 5 years is close to 50%. And annual cell loss after 6 months is around 3.9%. So there is a good paper, and it has mentioned that at 6 months, if the cell count is, and that means the graft will survive more. This is the complication rate. So overall complication, this is a busy slide, so I summarized it. Donor damage only 1.4%. Bleeding from PI site is very important. We cannot do more cases prior to surgery because of they come late. And you see that graft detachment in my series is 12% when rebubbling required is only 7%, whereas the graft detachment is pre-prepared, pre-punched tissue, preloaded tissue is higher as reported by many people. And we have seen that the steroid-induced glaucoma is around 12%. Primary graft failure that happens, initial 100 cases, that is there, 3 only. And secondary graft failure is around 6%. Graft rejection in my series is 3.8%. Repeat graft is 3.7%. So if you see the 2019 data, that with 600 eyes, you see that primary, the steroid-induced glaucoma was 7%, now it is 12.2%. And the secondary graft failure was 1%, now it is 6%. And rejection that time was 1.2%, it is 3.8%. Why this is this? This is a big question to me. Probably I have this data recently compiled, and in this 2.5 years period of COVID is there. A lot of patients actually didn't come for follow-up. They used steroid, whatever doses they are getting, and so secondary glaucoma are higher. If they have problem, they could not come to me or go to any corneal surgeon, something like that. So COVID has increased this data. This is my assumption of this. Then I am more conscious about DMEC PD. It is the peripherally trephinated. We know that superior cornea has a more endothelial cell than other part of the cornea, and then any peripheral part is more than the central corneal thickness. So I try to go peripheral while preparing my donor graft, and we compared and published our result in cornea in 2019, and that shows that after 1 year follow-up, that all Fuchs cases, the cell density is higher with DMEC PD cases. And if you see these two eyes, where it is, one is 4 years and one is like is almost same, and two eyes, one eye is the cell density is much lower where I have taken the central donor, or whereas if I take the peripheral one, the cell count is higher. This is two almost sequential surgery with a gap of 3 months. You see that after 5 years, both the graphs are tremendously very good cell count of after 5 years, it is 100 plus, close to 2200 endothelial cell. And other things, like as I said earlier, 80 years plus, I use a lot because we have to use because of short of donor cornea in our country, and we have to use, and we have shown that there is nothing wrong in using the above 80 years of old. Again, likewise, Rajesh showed that I use the bandage contact lens interface technique so that I can use one tissue for 2 patients. So continuous learning is going on. Lot of things are there, difficult in some eyes, but I am telling you that after this 1000, now it is 1200 plus. So 70% tissue will listen to, the rest 30%, you need a lot of tricks to fix those things. I have another question, that this patient had a clear graft on day 18, that is 3rd visit. I cleared him, go home now. He was from a different state, but he present on emergency with sudden loss of, dimness of vision, and this detachment happened after 3 weeks. So I do not understand why this thing happens. After complete clear, perfectly attached on 3 visits, 20/40 vision. So this is one. And another question, I am trying to think about what is literature says about silent rejection. This is a typical rejection of DMEC. So you see moderate, mild to moderate corneal edema with good amount of KPs. But again, you see the percentage of graft rejection in 3 years back versus now it is 3.8%. It is higher. Most of the reports are up to 4%. One report from Price showed that 5%, but that is for steroid for only 1 year. But all of my patients, so to say, is continuing with steroid. Are we missing silent rejection? So this is a case where you see that 2 years, the specular and the graft was fine. This patient came with KPs. No, this is a routine follow-up. I saw few KPs, and it is, to me, it is a silent rejection. And after treatment with step-up of steroid, this patient is doing fine, and no KPs, everything fine. This patient didn't have any symptom, and this patient is going good. So in my series, the silent rejection is around 38%. Out of these 37, 14 patients had silent rejection. Probably we are missing this silent rejection. So take home message is Indian other country, cataract surgery rate has increased to 5,000 per million population per year. We'll have more PBK or pseudophakic corneal edema because that is the primary indication in our country and developing world. We have also some amount of Fuchs dystrophy. We need to perform more and more EK. In the choice will be DMEC. We need more trained corneal surgeon. At the same time, we need to increase our donor cornea pool. That is only possible if we have robust eye bank support within our own community. And the last word, to start with DMEC, don't give up. Thank you very much for your patience hearing.
Dr. Bazak, do you want to unshare slides?
Yeah, I am trying. Something is happening. Yes.
Dr. Fogler, you had comments. You had comments on Dr. Bhagat's talk. Do you want to?
Yeah, I just wanted to highlight one point regarding bursting of the type 1 bubble. Usually what happens is if you have a closed chamber and you initiate the type 1 bubble, the aqueous doesn't have any place to get displaced. So progressively as the bubble enlarges, the counter pressure from the aqueous also increases. And then progressively you are increasing the intra-bubble pressure to try and make it to expand. And when it reaches the bursting pressure, you can have a rupture. So that's why I do a staged sequential air injection. That means I inject air to initiate the bubble. Then I do a parasynthesis, release the aqueous, so the counter pressure is reduced. And then when I go back and enlarge my bubble, I find that the resistance is much reduced. And you can safely enlarge the type 1 bubble, minimizing the risk of a spontaneous rupture.
Yes, I totally agree with you. But I usually do a routine parasynthesis before initiating the bubble. I know the parasynthesis may decrease the risk of the formation or make the formation more difficult because the air sometimes escapes from the parasynthesis. But this is usually what I do, a routine parasynthesis.
Okay. You're in mute.
Mute.
Any comments and any questions for the Lamella speakers?
Lamella speakers.
Yeah, lamella cataract, lamella corneal surgery. Okay.
And artificial speakers.
Well, I think it's been a wonderful session. I mean, I think we've overrun a little bit, but you know, so many high quality talks is really wonderful, and the Royal College of Ophthalmologists will be very, very pleased to collaborate with AIOS again for future joint webinars. It's been wonderful. I thank the speakers and my co-chairs and moderators and so on. And thank the, I have to thank the audience as well. We don't see them and they may not have heard the talks yet because this will be, this has been recorded so people can access it later on, and a copy will be deposited with the Royal College of Ophthalmologists learning platform as well. Great. So everybody have a good evening and see you next time.
Thank you, Christopher. For
Thank you very much.
Thank you so much.
Thank you. Thank you so
Thank
much.
you.
Thank you, Prof.
Bye.
Bye-bye, everybody. Good night. Bye-bye.
Good night.